Good evening, everyone, and welcome to the 20th episode of successful e-Gurukul series of surgical skill transfer and solving the clinical dilemma by the renowned gynecologist, well-known surgeon, eminent surgeon, I will say, and passionate teacher about transferring the skill to the others and or the young minds, Dr. P.C. Mahapatra, sir. So today's topic is laparotomy in obstetric and gynecology, surgical options, tips and tricks. So, sir, without wasting much time, I will hand over the session. Please, sir.
Thank you again, Dr. Sanjay and the whole team of Team Juventus for the 20th episode of this e-Gurukul program. And really, it's a passion for me and a compassion for me, both involved in that. And therefore, this is the 20th episode which is going on today. And in this episode, I welcome all the viewers, my favorite gynecologists, clinicians, surgeons across the country, and my students also who have really crossed me and excelled me. This is an opportunity to be with all of them. And this Juventus initiative has been going on for the last 20 episodes. And mainly the theme is on the surgical skill transfer and solving the clinical dilemmas. And we focus each episode on a particular topic. And today the topic is something different. And for that, I need the blessings of the Lord Jagannath, where I'm there, and everybody, and He, the Almighty, is blessing all of us in this corona pandemic. Well, this time I have selected a topic, laparotomy in obstetric gynecology. Now, if you think seriously about laparotomy in obstetric gynecology, some questions come to your mind. In the 21st era, whether laparotomy has to be discussed, number one. Second, is there a scope of laparotomy in the present context? Third, when the laparoscopic or minimal invasive surgery has been prevailing now, particularly amongst the youngsters, is it that it is a surgery of the yesteryears, or surgeons of the yesteryears perform this, or is it undignified who does the laparotomy rather than laparoscopic surgery? So all these come into your mind now while discussing laparotomy. And therefore, at this juncture, I purposefully wanted to focus on this episode, this laparotomy, whether what is the past, what is the present, and what is the future of this, particularly in obstetrics and gynecology. If you say obstetricians, without laparotomy, you cannot do the obstetric services, particularly cesarean and all that. But in gynecology, there is a change. There is a drastic reduction of the prevalence of the laparotomy. And the battle initially was there between laparoscopy and laparotomy. And of course, the minimal invasive surgery of vaginal surgery. Well, as a man of science, you must be judgmental. You must be very, very, I think, stick to the evidence, stick to the rationality. And therefore, your judgment on a particular patient, what is best for that patient, you should decide for that. That is the one thing. Second important thing, which I would again highlight, whatever procedures you do, the safety is the first. Safety of the patient is the first. It is not that you show your surgical excellence by any techniques, but safety is the first. Third important, upgrading your skill is very, very important. Whatever procedure, surgical procedures you do it, because the end point is the result. We want that the end point is the result, and that's why this is the thinking of any surgeons prior to surgery, whatever best for the patient, whatever safe for the patient, and whatever the quality surgery I will provide as a healthcare provider. With this introduction, let me again emphasize, particularly on this laparotomy in the present context, in the present episode of 20th episode. Well, the flow of events I will discuss, starting from the definition. What is the meaning of that? What is the evolution? When it starts history, we cannot ignore. And what are the types of abdominal incision? and the abdominal entry. Then what is the in obstetrics? What is the indications? And in gynecology, what are the indications? And what is the present status? And what is the future prospects? And after opening, what are the closure techniques which is the best? A refinement of the techniques or a changing strategy, changing trends and changing techniques. And little bit about the physiology. We should know about wound healing because that's a primary thing. We can do the job, but if wound healing is not perfect, I think you land in shook. And of course, we want absolutely a case surgery without a complications. I always say preventive surgery is important, and tackling complications after doing a complications and managing well has no credit. It's always how to prevent the complications, and if at all there is a complication, you can't know that, you can't be sure that in surgery there won't be any complication, but the complications, how to manage rationally and save the patient and save the life. That was the flow of events in my deliberation in the coming 2.5 hours. Now, coming to the definition of laparotomy, the various persons, starting from the literary persons to the technical persons, give a different definitions, but the basic theme and basic meaning is all same. Say, for example, in Oxford Dictionary, say that a surgical incision into the abdominal cavity is a surgical incision into the abdominal cavity for diagnosis or in preparation for major surgeries. Now, gone are the era where diagnostic laparotomy is being done. Now it has been replaced by endoscopic procedure. Mainly, we do a therapeutic procedure and a surgery, major surgeries for that. Wikipedia says that surgical procedure involving small incisions through the abdominal wall to gain access to the abdominal cavity. And that synonym of laparotomy is what is called a ciliotomy. The ciliotomy is a synonym of laparotomy. And the medical fraternity, what it means by that? It is a simple surgical incision into the abdominal cavity. Surgical incision into the abdominal cavity may be small, may be large. I think these are all called a laparotomy for that. Now, a great salute to this great, adventurous, visionary surgeon par excellence, Ephraim Magdwell, born in 1771 and died in 1930. So that's the period where in 1809 in Dan Valley, Kentucky, in 1830 he died, but in 1809 in Kentucky, in Dan Valley, the first successful laparotomy was performed that is recorded in the history. And that is done without anesthesia in the pre-anesthesia era, in the pre-transfusion era, in the pre-antibiotic era. See the guts and courage of this person way back in 1809. He did the first surgery in a case of huge ovarian tumor, thinking that it is a uterine tumor. He did it and the patient coughed and the whole ovarian tumor came out of the abdomen. And he did the first successful laparotomy, and where the relations and outsiders are watching with all in the periphery of the hospital and threatening Ephraim Magdwell, if at all there is something, we'll kill you. See the adventure, see the stamina, see the mental strength of this person, a determination of this person who has devised, and salute to this person of the first pioneer successful laparotomy, Ephraim Magdwell. Now, coming to the types of abdominal incision, I classify according to the location. There could be midline, paramedian, transverse, and several other incisions, other shape incision in the abdominal cavity. So out of which we'll discuss one by one: midline, paramedian, transverse, and others. Now, before doing any incision, any type of incision, these are some of the factors for selection of incision. First, we should know underlying pathology prompting the surgery. What is the pathology for which we do it? And accordingly, we do a transverse, or we do a midline incision, or we do a paramedian incision. Second important, suspicion of malignancy. If suspicion of malignancy is there, basically whatever technological advancement we have done in case of endoscopy, it should be condemned. Laparoscopy is not yet a very proved method for malignancy, excepting a very, very few instances. Third is absence or presence of upper abdominal disease. That's important because accordingly the incision will change. Understanding the comorbid state of the patient. That's the last thing. It's very important. While doing a surgery, we should correlate with understanding the comorbid state, whether the comorbid state in form of other medical ailments, or like a bronchial asthma, like a diabetes mellitus, like obesity, like hypertension, like cardiac disease. All these are really considerable factors prior to surgery for that. And therefore, understanding the comorbid state of the patient is very, very important for that. And these four are the selection criteria and factors for incision. And remember, these are safety first. Always, first is the safety. You cannot compromise the safety of the patient towards any operative procedures for that. Now coming to the midline incision. In the midline incision, site of the incision. I have already told the underlying factors and the factors responsible for that site, whether it is a infraumbilical or is it supraumbilical or is an extensible long incision from the lower abdomen to the upper abdomen. That depends on the underlying pathology and the disease process for which you are undertaking that. The length again will vary according to the disease process, whether benign or a malignant. And length also, normally in a case of benign, we normally employ in gynecology a subumbilical incision. Subumbilical midline is always preferred in obstetrics and obstetrics, particularly in cesarean. But in cases where there is a suspicion of malignancy, you have to give a larger incisions. And for this smaller incision, benign incision, maximum 10 to 15 centimeter length is required for that. Whereas in a case where there is a suspicion of malignancy or there is a true malignancy where you are doing a radical procedure, including the pelvic lymphadenectomy as well as parotid lymphadenectomy, particularly in case of ovarian, I think the length can be increased for that and it should be extended, and there could be extension to the upper abdomen, particularly supraumbilical for that. Now, what are the merits and demerits of this midline incision? Merits of the incision: decreased blood loss, because you are going directly from the linea alba in the midline when there is a junction of the fibrous tissue, where you open it and you don't go through the muscle. Decreased blood loss. You can have a rapid entry, immediately entry when there is an emergency. You should have a rapid entry. It should be easy. Exposure should be adequate, is usually adequate, and there's a minimal nerve injury. We are not dissecting the adjacent structures for that. That's the merits of midline incision. The demerits of the midline incision are hernia are more common. Dehiscence is there, various types of dehiscence, starting from the superficial dehiscence to the incomplete dehiscence to the complete dehiscence, and the intestines come out, the whole intestines and gut come out of that. So these are all varieties of dehiscence. Pain is more in a case of midline incision, and of course, last but not the least, the cosmetic purpose. Particularly in ladies, we do not want the extension upwards, and therefore the cosmetic part has to be taken into account for that. And therefore, this is the demerit, the cosmetic part. And this is the classical midline incision. You can see A, B, C, D, how it has been incised, the skin, infraumbilically, longitudinal incision, subcutaneous tissue, entry into the rectus sheath. After the rectus sheath, you directly, I think that is the area where the midline, everything is fused on either side, and you directly go through the linea alba. And you cut the linea alba and you enter into the fossa. The fossa, particularly above the umbilicus or just in the infraumbilical part, directly peritoneum is there. Whereas above the umbilicus, I think the arcus tendinous there, and above it, the whole fossa is either the posterior fossa rectus sheath, and then the peritoneum is there. When we go up, particularly supraumbilical, you enter that in layers, and these layer entry will go directly into the peritoneal cavity for that. Now coming to the paramedian incision. What is a paramedian incision? Midline is always in the center and it cuts to the linea alba. And in the junction between where the right and left side is junction, that is a fibrous tissue where you don't cut the rectus sheath and see the muscle for that. You just separate it. But whereas in paramedian, it's about 1.5 to 2 centimeter lateral to the midline. And this paramedian could be right or left. What is the advantage? Extensibility. It can be extended like a midline also it can be extended, but you don't have to carve around the umbilicus. You have to go straight. Exposure is really good, but there is an increased bleeding comparison to the midline, increased nerve injury, and of course, the same cosmetic part is there. It is less cosmesis as in midline incision. And gone are the days where paramedian was most often used, particularly in exploratory laparotomy. When you go for an exploration and in emergency situation, emergency cases, I think these are the cases paramedian was the first preferred. I remember during my undergraduate and postgraduate and in my early years, paramedian was considered superior to the midline incision. But a lot of studies after that last 3 to 4 decades have proved that it is the worst incision ever possible. And it's not an ideal incision. It is no way better than the midline incision. Earlier, they were telling that paramedian incision, the chances of hernia is less. The chances of the disruption, wound dehiscence is less. But if you compare vis-a-vis midline, now the paramedian has been obsolete. And it's not an ideal in the present context, which I say, it is not at all an ideal and a superior incision in comparison to the midline. Now coming to the common incisions which we gynecologists perform is the transverse incision. There are many merits of this transverse incision, and therefore this has been commonly used in obstetric practice. There are various types of transverse incision, out of which the most commonly employed incision is what is known as a Pfannenstiel incision. Then what is the Pfannenstiel incision? Pfannenstiel is just a suprapubic incision about 2 to 3 centimeter above the symphysis pubis and little curved size about 10 to 15 centimeter. And in the crease, it comes in the crease cutting so that the cosmesis is there. The pain is least because it's not going to affect in the respiration for that. And the strength of the repair is much better so that the incidence of dehiscence as well as the herniation is least in the case of Pfannenstiel. And of course, this is a much favored incision for all gynecologists nowadays. All of you must be doing that. But the only problem of Pfannenstiel is that it is technically little difficult than midline. It takes a little more time than the midline because there are vessels, there are nerve injuries there, nerves are there, vessels are there, vascularity is more often there. And that's why if you learn it, it is easier to practice. And Pfannenstiel, there are a lot of merits than the demerits which we find it. And another demerits is that when the pathology is something different, when we want to visualize the upper structures, and particularly in a radical procedure, this Pfannenstiel, there are some limitations of this use, and therefore we do not favor the Pfannenstiel incision. Kushner. Kushner incision is another type of transverse incision. Again, the difference between Kushner and Pfannenstiel is that you have to separate and dissect the subcutaneous tissues a little bit more upwards and downwards, because in a Pfannenstiel incision, the rectus sheath is cut transversely. In Kushner incision, the rectus sheath is cut in the linea alba, in the midline. You cut it, the rectus sheath in the midline, in the same as in a case of linea alba, and then separate it. And then subsequently, the rest of the procedures are also. That is the difference between Kushner. So it takes a lot of extra time in dissection. There is more of bleeding, more of nerve injury, and postoperative pain in a case of Kushner. Now, what about Czerny and Maillard? Czerny and Maillard are also a transverse incision, but little higher up than the Pfannenstiel incision. but this gives an age for exposure. Why? Because in that particular case, Cherny, the rectus muscle at the level of the insertion in the symphysis pubis is cut. You separate it from the level of the insertion at the level of the symphysis pubis. That is Cherny. And again, after the procedure is over, you stitch it with the interrupted suture. Maillard, it is a muscle cutting incision. So these are the procedures where muscle cutting incision, the rectus muscle is cut, and then exposure is much more. When this is suggested, Maillard suggested this muscle cutting, there was a lot of opposition because we are cutting the muscle and separating the rectus sheath. What about the number one? Immediately that will retract. Second, what will be in the future? There is a defect. But it is proved that rectus muscle has a lot of intersections from the fossa so that the retraction question doesn't arise. That is true. About the, after the end of the procedure, you do just a series of interrupted suture and then ultimately give a drain, and then the things will be united for that. There is no problem for that. Maillard is really approved. Another demerits of that is there. You have to cut the muscle. And the lateral end of the muscle, there is an important vessel called inferior epigastric veins and artery, which causes a real problem. So therefore, you have to identify the laterally the inferior epigastric artery and vessel veins, and the vessel bunch has to be coagulated or ligated before giving an incision on the muscle. That's the only thing. But it gives a lot of exposure for that. And therefore, in a case when there is obesity, in the case when even there is a malignancy, particularly in a cancer cervix or cancer endometrium, you can do this procedure, excepting where the upper abdominal pathology is there, you cannot do it. Otherwise, Maillard have a lot of exposure, much better than the Fan and Steel for that. Joel-Cohen. Of late, Joel-Cohen incision, all of you must be aware about this name. And when Joel-Cohen incision came from Israel, and this is particularly a modification of the old classical incision, particularly in a case of cesarean section. So Joel-Cohen incision is again a 3 centimeter, more than 3 centimeter above the level of the symphysis pubis in the mons, and it is a long incision about 15 centimeter to 18 centimeter. And here what happens? You don't do a layer-wise incision. You don't cut the subcutaneous tissue. You don't cut the rectus sheath. You don't cut the peritoneum for that. You just give a nick over the rectus sheath, and with the 2 index finger, you just strip it. Same thing, the subcutaneous tissue also you strip it, and the muscle, the peritoneum, you after splitting the muscle, you don't cut the muscle. After splitting the muscle, make a hole in the peritoneum, and then you again with the fingers, you strip it. And that is the difference. That is the only difference between Joel-Cohen and the Fan and Steel for that. And apart from it, rarely we may employ some of the peri-umbilical incision in a transverse. In a transverse, there are opportunities when there is a pathology in the umbilicus, say for example, the umbilical hernia or para-umbilical hernia, or commonly employed this in a case of umbilical. Rarely we find that umbilical endometriosis very rarely, but hernia is very common. So these are the cases when you want to go to repair, you have to do the paniculectomy. You have to remove the umbilicus in total, particularly in endometriosis, this is mandatory. In a hernia, if the umbilicus is normal, you can replace and you can transpose the umbilicus after the hernia repair is there. That you can do it. But the incision is a peri-umbilical incision, and preferred incision is a transverse incision because it adds to the strength of the hernia repair for that. Now, apart from it, the other incisions. What are the other incisions? Mini lap. Another time, I remember before endoscopic era, we were very crazy after mini lap because we know that the length of the incision is directly proportional to the morbidity, the pain, and therefore shorter the length, better is the morbidity. And therefore mini lap was very commonly used. And prior to that, long years, mini lap was used as a method of sterilization, mini lap tubectomy. And when laparoscopy came, I think there are advantages of laparoscopic tubectomy sterilization than the mini lap. But in rural setup, in a mass camp, still I think mini lap is acceptable for that. And therefore, mini-lap is there for that. Now, the current situation of mini-lap, what is there? When the mini-lap current situation, exceptionally, I will show you in my video, still in the present time, there is a place for mini-lap. Because when we find that the underlying pathology after investigations is found to be a benign, it's case of large over-insist. If it is a benign, unmarried girl, young age, you do a small incision about 4 centimeter, 5 centimeter, and then deliver it after evacuation. The size is reduced and you can do a cystectomy, you can do a oophorectomy for that mini-lap. So that is an advantage for that. And in minimal invasive surgery, the laparoscopy has come out. The lap-assisted mini-lap will help in tissue retrieval. Now is more common when in the era when in United States has withdrawn the morcellata for that. How to remove that? Either through the pouch of Douglas, but if the pouch of Douglas there is an adhesion, there is a endometric lesion there, or the rectum is adherent to that, the only option is that you have to remove the tissues, retrieval of the tissues by giving a mini-lap incision, lap-assisted mini-lap. And to add to it, open laparoscopy. The Hassan port is there. When you cut it, it's not a blind port entry, particularly in the cases where you expect that there is a adhesions below in a known tuberculosis, or there is a scars, multiple scars, where you don't have a direct entry for that. You cut it, open laparoscopy, and this is known as popularly as Hassan port. Many of the endoscopic surgeons, even veteran endoscopic surgeons, also use till date today Hassan port and open laparoscopy. Maybe that they are biased. They must have experienced bad events in the earlier time, so they are skeptical about it, and open laparoscopy is to be there. But what do you mean by mini-lap? What is a laparoscopic? The incision should be there. That will be defined that if it is a 20 millimeter, up till 20 millimeters, say for example, we use a 5 millimeter port or a 7 millimeter port or a 10 millimeter port. And if at all you want to have the morcellation, maximum 15 to 20 millimeter port, or a tissue retrieval is 20 millimeter. So up till 20 millimeter or 2 centimeter is considered as a minimal invasive surgery. And if the incision is more than 2 centimeter and up till 5 centimeter, we call it as a mini-lap. And more than 5 centimeter is what is called a major laparotomy for that. Now, coming to the gridiron. Age old, it's a long back. McBurn is way back 50 to 60 years back ago has devised and named it as McBurney's gridiron incision. Is in the right iliac fossa, and specifically that there is an oblique incision in the abdomen in the right iliac fossa, and particularly targeted for appendicitis. Now, J-shaped incision. There are some cases where the J-shaped incision is being done. In a case in gynecological setup, say for example, if there is a small endometriosis in the angle of the scar, or there is a hernia in the angle of the scar. So these are the cases you extend it and J-shaped incision on one unilateral side and do that. And particularly, this is one of the indications. Another indication is about if you're going for a ureteric anastomosis to the bladder. So implantation of the bladder, ureteric implantation of the bladder, you go through that, either through that J-shaped incision, and here most preferred is extraperitoneal. You can include it, extraperitoneal is most often preferred than intraperitoneal for that. Another incision is subcostal Cockers incision, which very often was used particularly for the gallbladder, cholecystectomy. And this Cockers has been replaced now. Almost majority of the cases of gallbladder cholecystectomy is done by laparoscopy. So no more this. Another on two sides of the subcostal margin, the rooftop or chevron incisions is being done for surgical conditions when you are going for extensive surgery, particularly for pancreatic surgery or extensive radical surgery in the upper abdomen. These are employed for that subcostal. There is no place particularly for discussion or purview amongst the gynecologists for that. And of course, periumbilical. I have already told that the indications of periumbilical incision is also there, and that's more often transverse than longitudinal for that. And lastly, I will say that extraperitoneal a little bit. Although, as per definition, extraperitoneal doesn't fit into the classical definition of laparotomy. Extraperitoneal, we are not entering in the peritoneum, in the cavity. So it's not a laparotomy, but extraperitoneal, because in gynecological setup, there are few indications where we do it, particularly the extraperitoneal cesarean section, which has long been advocated in a case of gross sepsis. Now, because of the innovations of the newer higher antibiotics, the procedures of the extraperitoneal cesarean, but still I have seen that some gynecologists prefer extraperitoneal cesarean and they do it. And there's been till today also, I know many of the versatile gynecologists doing an extraperitoneal cesarean section. Again, the bladder, entry into the bladder, particularly in a case of ureteric implantation, if you are going with the open surgery rather than endoscopic procedure, you go through the extraperitoneal route, and then you can do the ureteric bladder implantation for that. And retroperitoneal, you go, particularly, I remember Mitra's operation, where the radical procedure, they do it, and radical procedure, there are two incisions are given on either side of the inguinal canal, and for lymphadenectomy, they use it particularly for this extraperitoneal dissection. Until today also, the vulval malignancy, when to remove the uterus, when they remove the pelvic glands, I think extraperitoneal is employed for that, bilateral here. And these are some of the issues, although it's not truly a laparotomy, but there is some scope of this incision of the abdomen. Now, coming to the techniques, the tips and tricks, I'll go one by one. A very simple thing, all of you must be knowing it and all of you must be practicing. I feel I don't feel good to tell you, but these are the facts which I want to convey, which I want to transfer it, the facts which you are day in and day out know it. Although you may think that it's very simple and ordinary case, why you are telling all this for that. But still, I see, for the knowledge sake, for tidbits, I will say, because this is a session surgical skill transfer, tips and tricks for that, and how I do it, I will convey this. First and foremost is the site. This site you must select basing on the underlying pathology. As again, I'm repeating this, for what purpose you are doing it, and accordingly the site will be there. A case where you want to see the upper abdominal pathology, or you want to do a radical procedure, you think that there is a suspicion of malignancy, I think the midline incision is always better, and so that you can extend it upwards for that also. So that is important. Whereas in normal benign conditions of gynecology, and particularly for cesarean section, the site is always a transverse incision, suprapubic incision, and more often the phalansteal. That's very important. What is the length of the incision? It should not be unduly long. Say, for example, phalansteal is 10 to 15 centimeter length, is a curved, little curved for the cosmetic purpose. And whereas your Kushner incision starts from the symphysis, I think the anterosuperior spine, one anterosuperior spine to the other. The malar is also a larger incision that way. And also Joel Cohen is a larger incision. But length should be as small as possible. And the shape gives a better cosmetic value. And therefore, it is curved and in alliance with the crease, transverse crease of the abdomen, that should be there. Now, skin incision. Before giving a skin incision on the knife or electrosurgery, the marking we favor it. I have seen some cases where all of you must be noticed in a previous cesarean, that is most noticeable. If you're doing a previous cesarean section and you see this scar, you find the linea alba. Linea alba is not in particular alignment with the upper and lower. Upper is at one place, lower is at another place. This is mainly because of lack of marking. A position in a correct plane should be there. And therefore, this marking helps us. This marking should not be too deep. It's just a marking on the opposite side of the tip of the blade. You give it. That helps, number one. That apposition, the anatomical delineation and apposition must be absolutely normal. That's important. Second important, on either side you give a marking with equal distance from the midline. Don't at random, don't do the marking for that. 3-4 line at random. Don't do it. You have to give on the midline, on the linea alba is one linea, and then say for example 3 centimeter on the right, 3 centimeter on the left. And therefore, when you start a right incision, You start again 3 centimeter lateral to the marking line on one side and come and reach 3 centimeter lateral to the left side or right side, whatever you, in which position you just, so that the length of the incision should be equal. Normally what we find, otherwise what will happen? The length, one side, the left side will be longer, the right side will be shorter. So equal, this gives a good cosmesis values for that. And that is the value of the marking for that. So remember the marking, remember that the marking gives a good alignment as well as particularly the length either on the right and left symmetrically, because you can see that marking that yes, 3 centimeter this side, 3 centimeter this side, you will do it and you start again from the marking equal distance there and come out on the other side equal distance on the other side. That is the benefit, great benefit of the marking. But don't give a marking on the cutting edge. It should be on the opposite edge on the tip. Now incision, whether by knife or by electrosurgery, normally every people gives by knife. I will recall earlier there are a lot of reports that if you are going for a knife, electrosurgery is contraindicated. They say that if you give an incision on the electrosurgery, use electric current, the healing will not be good, and therefore scissor, the knife is always best. And there was again a lot of studies where you say that you change the knife after the skin incision. 2 blades are required. After giving an incision on the skin, the same knife or same blade should not be used in the deeper structures because there could be the chances of infection. This was concept when the infection was, prevention was there and how to reduce the infection for that. But that concept is not proved to be wrong. And with one knife also, with 2 blades, is unnecessarily complicating the trolley. And therefore, 1 blade is there enough for that if you're going for a knife. And electrosurgery, you can cut the skin by electrosurgery. Now there is soft cut available. The generator, I have already told in my previous episode on electrosurgical device, there are soft cut available where you can cut it. The skin can be cut with the pencil. I think that's not a problem and healing is not going to be jeopardized for that. Now after the skin incision is the area where subcutaneous tissue. It varies according to the depth of the fatty layer and varies according to the patient, obesity and other, particularly in females, we find the subcutaneous tissue is thicker and width is more. And therefore, again, if you are using the electrosurgery with the same pencil, you can cut it. And that's my usually earlier, prior to electrosurgical principles, we were cutting through the knife, and then with the seizure, we are cutting through the rectus sheath and separating it, everything with that. But now, because of the electrosurgical facilities, the cutting, blend, every current is there. We use that normally employed, and all gynecologists must be now adapted to that procedure. You cut it with the pencil, electrosurgical pencil, and cut the superficial layer, the subcutaneous tissue, taking precautions to the prominent vessels, which you see, you coagulate it, or if at all there is a bleeding, you just have a precision point and coagulation and enter into the rectus sheath. And in the rectus sheath also, just have a small superficial touch. And with that touch, the cutting current will cut it. Don't go deeper into it. The risk is that if you're deeper, you are cutting the muscle and a lot of bleeding will be there. So you can know just with the point, you just touch it and you can know what is the depth for that. And therefore, this is a unipolar current. This is not a bipolar current. This is a unipolar cutting or blend current, which you use it in the rectus sheath for that. And if there are prominent vessels of bleeding, you can use the bipolar thing because it gives a more of precision for that. So the precision point should be there. And there must be limits of the cauterization, limits of the hemostasis, which is being maintained. Don't over cauterize it. If you cauterize it and make it black, make it really, the crust will be more, the chances of infection will be more, and the collection will be more for that. And therefore, this is very, very important for that. So prior to electrosurgery, I was also doing surgery in the prior to electrosurgery where we are not using it. You cut it everything with the knife and the scissor, we are using it. But for the vessels, with the artery forceps or hemostatic forceps, you catch it and we are just ligating with the plain catgut. This was long since 10 catgut plane. I've used it in my earlier days prior to the extensive use of the electrocautery. And after the cautery benefit, unnecessary time is wasted by doing a suture, and therefore this has to be done. There are many people who find that let it be small vessels and at the end of the surgery, it will be closed for that. Don't bother about it and continue the surgery. I'm not in favor of that. I cannot do in a bloody field for that. It will, if you leave it for 5 to 10 minutes, the blood clotting mechanism is such that the smaller vessels that will be retracted and bleeding will be less. Bleeding will be stopped for that. But this is a bloody field and it will be a mess. And therefore, absolutely, you should be very meticulous and give attention to the hemostasis part. Because again, I'm reminding hemostasis to the surgeon, oxygen support to the anesthetist is the primary factor in the intraoperative period for that. Now, there are some problems in the scar. If there is a previous scar, what should be the approach? And what will happen? Is there a problem? Now, previous scar, normally suppose there is a previous cesarean section or previous operations in gynecology, say for example, an ectopic or some endometriosis or myomectomy for that, that could be a previous scar. So how to approach for that? And that scar can be a longitudinal, can be a transverse. More concerns occur when there is a longitudinal scar. In the previous surgery, there is a longitudinal scar. The debate comes whether you excise this scar and do at the same level longitudinal, or you go in the transverse plane in the pharyngeal scar. There are advantages and disadvantages of either of these. The main advantage is that if there is a previous longitudinal scar and you are going in a transverse plane in the suprapubic area pharyngeal incision, again, the chances of woundoiscence, chances of herniation is least. That you can save it. Because if you are cutting to the same weak point, the chances of hernia will be more for that. But the demerits is that there are two scars, one vertical, one transverse. But the patient safety is very important. The patient convenience is very important for that. The only problem it occurs when there is a very ugly scar, a wide scar in the midline. What will you do? And there is a wide scar in the midline, there is a weakness, there is a divarication of the recti, there is a herniation along with that. These are the only cases you excise the scar, and while closing and repairing, give attention like a hernia repair, like a position of the muscle, like to prevent the divarication of the recti. That gives an opportunity in the same. Otherwise, the transverse is the best if there is a previous scar for that. That's the only indication I will prefer for that. Otherwise, don't give it for that. And the problem of the previous scar is that if you're using the electrosurgery, it's always better than when you're using the knife. It cuts well and the hemostasis is being maintained, because in the scar, initially at some places, because the fibrosis, there will not be bleeding, but deeper, it will be more of bleeding for that, the previous scar. And underlying structures also, separation will be difficult. Now, in the transverse incision, if there is a previous transverse scar and it is a visible scar, you have to excise the scar in the subsequent. And if there is not visible, it's a very good, and it's a thin, you don't need an excision. Otherwise, in a transverse, you just excise for the cosmetic purpose for that. Then comes the rectus sheath. In the rectus sheath, knife and scissors versus electrosurgical device. I have already told that now when we are acquainted with the electrosurgical device and with the pencil and the point, it's much better to cut it, and because the hemostasis is better maintained for that. Now, a little precaution of incising the rectus sheath, either by knife or scissor or electrosurgical device. Be cautious about the lateral extension. How lateral we go for that? Maximum, you don't cross the lateral border of the rectus muscle. That's the mainly principle for that. And many people, they go lateral to the extension of the vessel. And this is mainly required when there is a large mass which can be delivered. And you think that if you go laterally, the space will be little more. Yes, the space will be little more. But there are demerits. What demerits? If you go lateral to the muscle, the inferior epigastric vessels are there underneath. There is less likely for damage to the inferior epigastric vessel because it lies below the muscle. It is not going to be affected. But the ilioinguinal nerve and iliohypogastric nerve branches will be cut, and neuronoma is manifested in some cases for that. Most important is that there is a lateral triangle which is there lateral to the muscle, and the apex is in the oblique, external oblique or internal oblique, and that is the weak point. And therefore, if at all, if you are removing a larger mass, go laterally, expose the lateral triangle, and while closing, you must close the lateral triangle on either side. Otherwise, in transverse incision also, hernia is less, and if at all the incidence of hernia is there, it will be on the lateral aspect, angle. So that is very important. Take a special precaution in closure for that. So beginning, if it is not necessary, don't go up till that. Care to the deeper structures. The muscle is there, and therefore you do in such a manner that the rectus sheath should be separated from the muscle. At times, what happens, the muscle is densely adherent to the rectus sheath, and therefore the electrosurgical device helps if you use it with the pencil. Now, what will happen to the muscle? And the rectus sheath, if you give an incision, then you separate the rectus sheath from the muscle above and below, because we require a space for that. In Kushner's incision, you have to separate much more, but in Pfannenstiel, don't separate much more. There are many, in my early days, our teachers were preaching that for space in cesarean section also, you have to reflect the rectus sheath from the muscle right up to the level of the umbilicus. But if at all there is a, it's not necessary for that. Halfway from the umbilicus is enough for that, because if you dissect it more of perforating vessels, more of tissue edema, more of postoperative pain will be there. So least dissection will be much more better. Whatever is desired, required for the surgery, particularly for cesarean or for a hysterectomy, that you do it. That's the important thing which I will say. So separation from the sheath, the extent is important. And of course, the hemostasis, there are perforating vessels. The hemostasis is much more important for that. Coming down, lower down, the pyramidalis muscle. Everybody must have experienced the pyramidalis muscle length and width varies from individual to individual. At times we find the pyramidal muscle is so long, about 3 to 4 centimeter length. And at times it is 1 centimeter, 1.5 centimeter length. And I have seen people are doing an incision. Don't go above the pyramidalis. You have to separate the pyramidalis, lift it and separate it from the rectus muscle. If you go superficial to pyramidalis muscle and you can separate the rectus sheath from the pyramidal muscle, I think it's not good as far as the bleeding is concerned. More of bleeding will be there in the mons pubis, and postoperative discomfort will be more in the lower part for that. So always separate the pyramidalis from the rectus sheath, and deeper to the pyramidalis, you find out a space, not superficial to the pyramidalis. This is a very important tips and tricks I'm giving. Now coming to the separation from the parietal peritoneum. Normally what we do, if we separate it, find out the midline, then strip it, and we find that the peritoneum is visible on that. The only problem occurs in a previous scar, in a previous surgery, where the muscle is fixed to the pyramidal, to the peritoneum, deeper structures. There you have to separate from the parietal peritoneum. Parietal peritoneum, you have a dissection from that and separate from the parietal peritoneum by scissor, either on this side, both sides, so that you get a space for the peritoneum for that. The second option is that, and this is particularly important when we are giving the incising the peritoneum in the transversely. When we are giving incision on the longitudinal, the midline, longitudinal plane, you are giving incising the peritoneum. This is not absolute necessary, but a little stripping of the tissues is necessary. The stripping of the muscles on either side is necessary. But if you are going for the transverse plane, I think it's better that you separate it, dissect it from the sheath. Now, muscle splitting versus muscle cutting. I've already told that we always do a muscle splitting surgery. Majority of the cases that is fitting into the concept of Pfannenstiel. Muscle cutting, when we do, when it is a desire for that, when you are not able to approach, when you want more of space, when radicality could be a procedure for that, you cut the muscle cutting incision like a Maillard. And even the Maillard incision is not that long incision. You give for a Pfannenstiel short length, but you cut the muscle. But again, taking care of the infraepigastric vessels in the lateral part, and then the bleeding. And of course, while the closing, you must give an interrupted position suture for that. Now, approach to the internal epigastric is very, very important, and this must be taken into account when you are doing the muscle cutting incision for that. And particularly in a case where in radical surgery also, in obese women, you cut it the muscle, and before cutting the muscle, identify the internal epigastric artery, and then just coagulate it or suture it. I mean suture it. Now coming to the peritoneum next. Site of entry is important to have a site of entry. In normal cases, when there is no scar, the site you can select it. But the problem arises in a case where in an obstructed labor, or in a case when there is a previous cesarean, when the bladder is lifted up, there the peritoneum, the site of entry is little higher. So remember, higher site of entry into the peritoneum, I think prevents the bladder injury for that. And that's important, site of entry. And method again, by seizure or by electrosurgery. And usually my preference is to give a transverse incision rather than the longitudinal incision. And a previous surgery, there is a lot of problem. When there is a previous surgery, depending on the previous surgery, that if it is a ill-done surgery or the patient's profile is for more of adhesions and all that, at times you are not able to enter the peritoneal cavity. Underlying adhesions are much more for that. Be cautious about it. There could be adhesions of the gut, there could be adhesions of the omentum, there could be adhesions of the bladder, and this very, very careful about it. One thing, very atypical case I will find out. When you are cutting the transverse peritoneum in the transverse plane, very rarely you encounter a patent urachus. It's an obliterated ligament. You find out there is not a problem. You just cut it. There is not a problem. And at times what happens, I have seen in my life one case which the urachus was patent and it was not tied, and that postoperatively the urine is leaking through the abdomen, and that is could be avoided. Very small tips for that. You just, if you are finding a tough structures or a thicker structures, you just ligate above and below and cut. That's very important special care you take it. And at times a failure of entry, you're not able to get entrance into the peritoneal cavity, where because of the previous adhesions, there you must be very careful. Even without entry also, enter into the lower uterine segment, do the cesarean section and complete the procedure for that. And of course, the transverse versus vertical, it is your choice, your preference which matter for that. But the main two things I will again emphasize: below is the bladder, underlying is the gut. You must take special care in that particular thing. Otherwise, you are going to injure the bladder and injure the gut further. This is a typical fun and still incision where I will show, and my surgery also medical surgery. You see in the A, it's a relatively carved suprapubic incision, and it's not a very long incision like a Maillard or a Czerny incision for that. And how the rectus sheath is being lifted from the muscle. After incising, the rectus sheath is incised, and then on either side it is gone, and then the upper and the lower flap is stripped off from the muscle, but don't overstrip it. Then the last part is the peritoneum, where either you can give a longitudinal incision or a transverse incision for that. This is a Kushner incision, which I have told. Kushner is not a very advantageous incision for that, and therefore the main thing is that you have to dissect above and below the subcutaneous tissue a long distance, because you have to giving a midline incision on the rectus sheath, and therefore Kushner is not being advocated an ideal incision for that. And of course, this is a classical Maillard incision where the inferior epigastric vessels are ligated, and then you go and cut in the midline, particularly on either side, with preferably with the cautery, so that the bleeding will be less, and there is no retraction. And at the last, you have to oppose with the interrupted sutures, multiple interrupted sutures for that. And believe me, if I say that transverse incision and midline or paramedian incision, I was just thinking that the transverse incision was named after a person, like a Pfannenstiel or Maillard or Czerny. But midline incision is not fitting to any person. It is just an anatomical line for that. That's just a coincidence for what I do not know, but this is not related to the naming of a person for that. And this is some of the peri-umbilical incision. Peri-umbilical incision is there, either a transverse incision Depending on the extent of the pathology, you go more laterally or more medially for that. And the underlying thought that there is a case of abdominoplasty where you can do a simultaneous procedure of abdominoplasty along with the procedure of other surgeries where the undermined areas, exposed skin and subcutaneous tissue, they are just exposed, and the subcutaneous tissue you can excise it, you can do a good repair of the divarication of the recti, and then appose the skin in such a manner that the hernia is being taken care of. Now coming to the closure technique. The closure technique, there's a lot of innovations, lot of changes in the closure technique for that. Lot of innovations and a closure technique for that. And number one, there is when initially in our early days, we used to close with the catgut. Number one catgut, we used to close everything. The peritoneum, the rectus sheath, and main closure, the strength of the incision, the tensile strength is mainly dependent on the sheath. So sheath is a very important thing which you find it out. And at that time, longitudinal incision was most often found, and midline incision, and of course, the suture material was catgut. And therefore, these are the two main factors responsible for wound dehiscence as well as hernia. And therefore, there is an innovation in the suture material for that. And after some realizing this, then if we are doing a transverse incision, we are using the innovations of the delayed absorbable suture like a vicryl or PDS, that is best for that. And when we are giving an incision, particularly prior to the vicryl and PDS, prior to that vicryl and PDS, we were using proline or polyamide suture in the sheath, either in the transverse or in the midline. Then subsequently, in the transverse, we change to the polyamide, they change to the vicryl or PDS. And if it is a longitudinal linea alba, we usually go for the polyamide or a proline suture for that, non-absorbable suture for that. But there are a lot of demerits of the non-absorbable suture, and this non-absorbable suture, that postoperative discomfort is there in the non-absorbable suture. But in that, there was a classical dictum that when there is a prevention of hernia or there is a hernia repair, always use the proline suture for that. But still, I find nowadays the studies have also shown that the delayed absorbable suture like a vicryl or PDS suture is equally better or much better than the non-absorbable suture like a proline. And that's why I've changed the concept, and nowadays I'm not using any proline or a polyamide in the deeper structures in the sheath, and restrict myself to the vicryl or PDS. If you compare vis-a-vis PDS and the vicryl suture, the vicryl is little inferior to the PDS. The strength, the tensile strength is 3 times more in a case of PDS suture, but the demerits is that more number of throws is necessary. At least 4 to 6 throws are necessary in a case of PDS suture than in a case of vicryl. So suture material is a very important changing trends in prevention of hernia as well as prevention of wound dehiscence for that. And that has changed the scenario in the current concepts for that. Suture material is very, very important for that. And of course, the suture material, I will come with the skin closure, I will tell about the different suture material. But this is about mainly the sheath and the underlying structure first. Now, layered versus mass closure. In a case where in a transverse incision, you cannot do a mass closure. You have to go for a layer. But in a case of longitudinal incision, another opportunity is there, the mass closure versus layered closure. So in a case where there is a midline incision, you can do a mass closure, and the mass closure is equally effective than as compared to the layer closure for that also. Now, continuous versus interrupted. Again, earlier, the surgeon's philosophy is there. The sheath should be interrupted or the linea alba should be interrupted for that. And that's they prefer a Smith-Jones interrupted suture, far and near suture for that. And therefore, they feel that the interrupted are much more than the continuous. But we gynecologists, majority of the gynecologists say that continuous either locking or unlocking, whatever, it's a choice of yours, but it's a running suture, saves time as well as prevents, and there is no other real advantage over the interrupted suture for that. So continuous is always best. And in addition to the continuous, you can give 2-3 interrupted after the end of the procedure to augment the particularly the tensile strength and the suture, I think the sheath. That is possible for that also, and that also we give it. Locking versus single running sutures, the surgeons usually say that single running is much better because it doesn't compromise the hemostasis. But locking suture, we are using it for the last so many decades, and personally I feel that there is no difference between locking and single running sutures in a case of sheath. But single running locking is not necessary in a case of peritoneal closure or the things is there. Now, about again, while the closure technique, particularly for peritoneum, the parietal peritoneum, the concept now for the last 2 decades, it has come that the visceral peritoneum in the cesarean section and parietal peritoneum need not be closed. And there is no necessity of closing because we know that within 6 hours, the edges of the peritoneum oppose automatically without closure for that. That's true. That's the true, but particularly, but I have one experience in which I have seen one surgeon doing a cesarean section, and within 6 hours, I find that the patient was in shock. And there is an abdominal distension, any pale. So immediately I thought that could be intraperitoneal hemorrhage, and the surgeon called me. I went and I told that immediate surgical intervention with blood is necessary. When I opened, I thought that it was from the 1-layer closure. At that time, they were giving 1-layer closure of the muscle. And I was thinking that there is some problem in the muscle where immediately within 6 hours, why there is a bleeding, so much of bleeding for that. But absolutely the wound was healthy. The uterine closure was absolutely normal, but there was a spotting vessels in the parietal peritoneum. And from there, the whole abdomen is filled with the blood and hemoperitoneum is there. So what I give a message, you can leave it or you can close it. If you leave it, at least see for hemostasis. And from that day onwards, I always say there are spotting vessels in the parietal peritoneum or in the visceral peritoneum also. And in the you just fulgurate it, coagulate it, and then you can leave it for as such for that. Then again, the drain. The drain we give it passive versus active. Passive drain, simple example is a passive drain. It's not a suction drain. It's just a drain, corrugated synthetic drain, Romovac drain we give it. An active drain is always connected with the pressure, a suction negative, a Romovac. So these are examples of drain, but where you give it, drain. All cases, drain is not required. I remember Halstead told, what are the indications of drain? He told in one line, when in doubt, drain. When in doubt, drain means if there is a doubt that there is a oozing, if there is a doubt that there is a subcutaneous fat is about more than 3 centimeter wide or depth. So these are the cases when there is a chance of collection below it. And these are the cases where you give a passive or active drain. And active is always much more preferred than the drain, passive drain. And when you are using particularly a simple suture, I think drain is a must for that because the underlying collection is there. If you're not using the mattress, the simple suture to the skin, you use the drain in below, and that will take care of the collection for that. Then coming to the skin closure, because skin is being seen, and this is the outer signature of yours as a surgeon. So how to do that? Always people say that the cosmetic part is there for that. So this is important. And then skin closure, I will just deal with the last part after the layer closure is there, starting from the peritoneal, muscle, rectus sheath, subcutaneous tissue, and skin. In the peritoneal closure, I was just telling that closure versus non-closure. And if you're not closing it, see for the hemostasis. Continuous running is important. And suture material, we have said goodbye to the catgut. If you're using the catgut, it's okay for the peritoneum, but don't use the catgut in the sheath. Always the delayed absorbable, good tensile strength suture like a Vicryl or a PDS. Closure versus non-closure. Continuous running suture is, you can use it, and precaution is about the vascularity for that. Every steps, you must see that there is no bleeding. muscle. After that, the muscle is there, and see, in the muscle, you take a precaution that simple apposition. Many people say that we leave the muscle, don't oppose it. There are demerits of this not opposing the muscle. In the repeat section, you find that the rectus sheath is fixed directly to the underlying fossa, peritoneum, and that becomes a problem. And therefore, just simple apposition of the rectus muscle is very good, and you always do with a simple suture. Don't make a tight suture for that, just a simple apposition. And before apposing the rectus muscle, two sides you inspect. One is the lateral angle. I have already told, the lateral angle triangle is on the either side is more. If you have gone dissected the rectus sheath and the external and internal aponeurosis more laterally, there is a lateral triangle on either side, and you must oppose it. You must close the lateral triangle to prevent hernia. That's one. Second important, the undersurface of the muscle, rectus muscle undersurface, there could be a small oozing. I have seen cases where there is a large hematoma persisting after the delivery in a cesarean, and there is a rectus below the rectus sheath. There is a hematoma, and continuously there is a bleeding occurs even with the exposure for that. You have to, and therefore a little precaution. If there is a bleeding on the surface of the rectus muscle, you must visualize and just coagulate that particular area. Now coming to the rectus sheath. The rectus sheath, I have told that the spatial areas, again I will emphasize the angle. I have seen, and remember this will pay you in future. Interrupted versus running. Running, locking suture is always good for that. But the main thing you find that while the giving a suture in the rectus sheath, the angle must be very, very important. The angle, the lateral angle, apart from the lateral angle, the angle from your side, if you're standing on the right side, your right angle should be stitched first. Don't start from the left angle and then automatically it will go, it may slip. So therefore, securing the angle from your side first is important. I always give importance for that. Even for the uterine muscle while doing a cesarean section, you do that. So angle of the rectus sheath, again, same thing, because the triangle and angle, remember this. If there is a triangle, you opposite, close it, and the angle from your side, you close it and then start from the opposite side for that. So special precaution has to be taken. You can do, you can have an interrupted suture, but all gynecologists, including myself also, I'm much more comfortable with the running, locking suture rather than the simple running. It's a locking suture, and preferably with the PDS or Vicryl. So that is absolutely necessary. Either 10 or 1, you can do it. And there must be symmetry. It's a depth and width of the rectus sheath must be symmetrical. We give it, say for example, 0.5 centimeter or 0.1 centimeter apart and 1 centimeter depth. You give it so that the depth and width should be very, very symmetrical for that. And suture material, again, Vicryl PDS. Earlier we are giving proline. I think say goodbye to the proline. You can use it in a case where there is a hernia. But remember that Vicryl and PDS are much more better suture than the proline. Because proline, what happens? The multiple throws has to be given. If you are giving a proline, the sutures must be undermined. And otherwise, in the post-operative period, when the angle of the scar, you find a tender spot there continuously lasting for months together. So that is the main advantage for which I don't like that. And subcutaneous tissue, either you can give an apposition or put a drain. As I have already told, if there is a thicker subcutaneous tissue, either you oppose it with the interrupted sutures and close the skin, and then otherwise you put a drain. If there is a subcutaneous tissue is much more, particularly in obese individual, you can have a oppose it and put a drain for that. That's much better. Now, therefore, a skin closure. Now, coming to the skin closure, it could be simple. Simple gives a better post-operative vision. I think the thin scar will be better if you give a simple, and therefore all plastic surgeons are much more familiar with the simple stitch for that. Simple buried, where the knot is buried, there is no added advantage for that. But simple interrupted suture in the skin is always better for that. And then the transverse mattress. The transverse mattress, the mattress suture is transverse, is much more hemostatic, but it is not good as far as the post-operative the healing is concerned for that. The vertical mattress, again, Vertical mattress is much more preferred in the suprapubic area, particularly in females where the subcutaneous tissue is much more. So vertical mattress gives a deeper entry and closer to the and closes the underlying subcutaneous tissues. The bleeding will be closed, the dead space is closed, and that is much more preferred for that, the vertical mattress. And the suture material, normally earlier we are using the skin, where silk, but now the polyamide, number 30 polyamide with the atraumatic cutting needle, I think this is unique. And polyamide is much better than silk, because if at all there is a collection, if at all there is a superficial dehiscence, you don't cut it. You just cut one or two and just dress it, and there is no need of a secondary suture for that. But silk, you have to cut it, and many often we find that secondary suture is necessary when there is a collection for that. So either a simple with a drain, or with the subcutaneous, or with the vertical mattress. If at all we are giving it a vertical mattress, give it vertical mattress, or a subcuticular. Commonly employed now is a subcuticular. You can give a monocryl or a 20 vicryl or 30 vicryl. Smaller dimensions is much more preferred in the subcuticular. And after a position of the subcutaneous tissues, you can give a subcuticular stitch, and which is very convenient for less hospitalization, and the patient's psychological satisfaction is there that the stitches are not being removed for that subcuticular. But continuous skin is not preferred particularly. But this is all about the suture. The simple buried, transverse mattress, vertical mattress, subcuticular, and continuous. Now the alternative of suture is a stapler. The stapler is much better in terms of the scar. The scar is much better in the case of the stapler as compared to the vertical mattress for that. Vertical mattress, the advantage between the vertical mattress and subcuticular is that initially subcuticular, if you give it, the incision, the cosmetic is very good. It looks very nice. But after 3 months, when she comes for a checkup, you find a single line in the subcuticular. But here in a vertical mattress, because the hemostasis is very good and a position is very good, if you are using the polyamide, initially it doesn't look well. But after 3 months, you find out, and there is no line can be seen for that, and it's so beautiful scar for that. So it depends on your individual choice and the circumstances, but these are important. Simple vertical mattress, subcuticular. Forget about the simple buried, forget about the transverse mattress and the continuous in the skin closure. Now, the alternate option is a stapler. Stapler, if you use it, the incision, the cosmesis is much better as compared to the vertical mattress, and therefore stapler can be used it. But when the subcutaneous tissue is depth is more, or in a case of obese individual, you have to put a drain. Otherwise, the postoperative collection will be there. So stapler is very good, and a position is much better. Now, the chemical Dermabond or cyanoacrylate, or some of the glues are there which can be used for that. I've used in many cases, both in laparoscopic port as well as in large incision also, and Dermabond can be also effective and can be an option for that. And you can use the Dermabond instead of a suture for that. And again, if you are using the Dermabond, when the subcutaneous tissue is there, you must oppose the subcutaneous tissue or put a drain for that. Same thing happens with the surgery strip, and surgery strip just apply like just applies a special material of surgery strip, and that applied opposing the skin edges, and therefore that is very good, and that was available for that. Now let us start how to open and close. This is a case of cesarean section where I'm going for that. Skin is cut with the knife, and these are small vessels. At the end, at the lateral end, there are vessels which you have to identify, and precision is there. You catch hold of this vessel and coagulate. Otherwise, don't catch the tissues, so that at the end of the procedure, you find a very bad the scar is there, and therefore the excess of cautery will give rise to more of collection, and then enter into this enter gradually after the subcutaneous tissue. Everything is cut with the pencil, electrosurgical. Then I have cut the rectus sheath, and this rectus sheath, you just touch it and it will go. And remember that you don't have to dissect it much more, as because we are giving the phalangeal incision in all these cases, and the length of the incision is never exceeding 15 centimeter, 10 centimeter, 12 centimeter maximum. We go it for that. But remember that while using this cautery and cutting with the pencil, you must be very, very careful that don't go deeper into it. Just touch the rectus sheath and automatically it will go. And this needs a little practice for that, how depth we can give it and how smooth it can be there. And you can itself know how the depth of penetration for that. Just touch it and you find out. And now see the upper segment, then the lower part, the lateral part we see, don't go more than the rectus sheath for that. Rectus sheath away from the rectus sheath, because we don't go more laterally for that. And whatever is required for this is a case of cesarean, we don't require to have a extension of the incision laterally. So these are all very careful about the hemostasis, and this upper part also can be separated with the same electrosurgical device rather than the seizure, and that is an advantage, that the bleeding will be less for that, and you can clearly separate the upper and the lower part for that. And again, I'm very, very particular about the hemostasis for that. And this lower part you are separating again the pyramidalis, which I've already told that pyramidalis should be separated from the rectus muscle. And this is the pyramidalis. Can you see that I'm not going superficial to the pyramidalis? I'm going deeper to the pyramidalis and separating the pyramidalis from the rectus muscle. And that is to be done because it avoids a lot of pain, it avoids a lot of bleeding, and if you separate it from the mons pubis for that. So that is the trick in which you go. And now this is the case of the peritoneum. The parietal peritoneum, you go strip the muscle, you don't cut the muscle. In a case of cesarean, we don't usually cut the muscle, and identify, go to a higher area and then cut it so that the underlying tissues are not being injured for that. And again, I'm giving this transverse incision, taking care of the vessels on the edge, and then to the uterovesical fold of peritoneum, entry into the lower uterine segment. As usual, I've already demonstrated in the cesarean section episode, but again, I want to highlight because I have to show how the steps of laparotomy and the incision and opening, entry and closure to that. So that's why I wanted to show this particular thing, because in obstetrics, there is no, you have to go for that. There is no endoscopic method for delivering the baby till the present time. So still, so there is a mandatory thing that we should know how to do a laparotomy, how to enter into the abdomen for that as an obstetrician. And a gynecologist, you can have an option that 80% of the laparotomy, which was done earlier, has been taken over by minimal invasive surgery or laparoscopy, but still we require the 20% of the cases where still it is the place of laparotomy is there, and now the delivery of the head and delivery of the baby done by the head delivery by vacuum. Always I do it, and then after that the uterine closure. I'm not going to show the uterine closure today. After that, you just entry of the abdomen I have shown, and this is how you do the closure of the peritoneum. And this is a layer peritoneum. This cannot be a mass closure of that. And rare peritoneum running suture again with 10 vicryl. You can give it, or this also, this you can give it with the catgut. That is not a problem. But rectus sheath, don't use the catgut for that, because this is an area where the strength is much more important for that. And then in the rectus sheath, you take a special precaution on the angle for that. So this is first layer, then apposition of the muscle. This is the apposition of the simple apposition of the muscle. You do it a series of at least a 3 to 4 layer, 3 to 4 interrupted suture. You give it to oppose the muscle, and after the muscle, the same. Your own area, the angle you must go do it first, and then start from the other areas. This is what I want to highlight and show you how it has been done. So the right side I've done it, then I started from the left side, and then this is absolutely, the suture cannot be a catgut. It must be a delayed absorbable, like the vicryl or PDS. And then this is a case where I have given the transverse the vertical mattress. The vertical mattress is given, or you can give the subcuticular also. This is one demonstration of the Dorma bond. Dorma bond is there in the cyanoacrylate chemical glue, which is there. Again, this is a case where after due hemostasis is there, I'm applying this to see that how effective it is. I have tested this particularly in vaginal surgery also, abdominal surgery also, in cesarean, in gynecological surgery, in laparoscopic surgery also. And just is very simple, and you just apply it with the position of the skin and apply this. About 2 times we apply it, and then things leave it as such. So this is how we just stretch it with the Ellis forceps on either side so that the edges come together, and then you apply this chemical, and things are okay for that. And that is also very easy. And of course, the cost factor is little more, but still it is not very popular. Till today, it is not very popular, the Dermaburn, and you can use it for some reason or other. Maybe that they are not able to supply, or there are various agencies starting from Nectacryl to Dermaburn to various agencies, various companies which you manufacture. At the end of the procedure, you can see the scar for that. And this is one way you can do it for that. Now, then we go to the next area where laparotomy for obstetrics and laparotomy for gynecology. So laparotomy is spectrum in obstetrics. Say the first and foremost important is a cesarean delivery. There is still date, there is no method of endoscopic delivery, and I'm waiting for the time when the endoscopy can be used for delivery, when the theory of minimizing and maximizing comes, when you enchant a mantra and the baby will be reduced from 3 kg to 3 millimeter, and you suck out from the hysteroscope and then enchant a mantra of maximizing, and 3 millimeter baby can be enlarged to 3 kg and then hand over to the couple for that. And again, it's a fantasy, and therefore cesarean delivery is a must, and everybody, all gynecologists and obstetricians must be very well confident in the laparotomy. The opening and closing is much important, and there should be least complications in that. And cesarean is first. Second important is a peripartum hysterectomy. We have discussed at length about the peripartum hysterectomy, and particularly the cesarean hysterectomy and PPH and rupture of the uterus. All these are peripartum hysterectomy. Rupture uterus can be by in the two things, by silent rupture during pregnancy or during labor. There could be rupture uterus, which can be only tackled with the laparotomy for that. Then pelvic hematomas. There are some pelvic hematomas, particularly in a supralevator hematoma. The approach should be from above, whereas infralevator hematoma, the approach should be from below, the vagina. So pelvic hematomas can be tackling PPH either by compression suture or bilateral internal iliac ligation. You do it, and then of course this is an area where they have used it, and God forbids, and I pray God that till today I have not done a single case of bilateral internal iliac ligation for PPH or a compression suture for PPH for that. So somehow I believe in the only preventive aspect. The internal iliac ligation unilateral, I have done it for a pelvic hematoma, a supralevator hematoma, and a rupture uterus. On that side, there's an extension. So single unilateral. For PPH, I think the preventive is much more important as far as my philosophy is concerned. The trauma is again another area for that. Then about the ectopic pregnancy. One of the era when there was a dictum was that when the patient was hemodynamically unstable, laparotomy. When the patient was hemodynamically stable with tubal rupture, go for laparoscopy. That yesterday's contraindications are today's indications. And I say that when the patient is fit for anesthesia, she is fit for surgery and endoscopic procedure also. But in some cases where the endoscopy is not available, in a country like India, our gynecologist in periphery can detect that and immediately do it even with the local anesthesia. Even with the local anesthesia, they can open and close it and save the life, rather than sending the patient to higher center. Many times they will reach it, and presuming that they will do it with the endoscopic approach, the life is gone. So there is still, in country like India, in this particular setup, I will favor that, yes, there is a place for laparotomy and acute tubal rupture, then rupture uterus. They can do it with the local anesthesia in the periphery also. And I have served in the periphery. I have a lot of experience of doing this, tackling this with local anesthesia. And now non-communicating horn in pregnancy, ectopic. ectopic, non-communicating horn, rupture of the non-communicating horn of the pregnancy, giving rise to the internal hemorrhage. This is one area where you can do a laparotomy. You cannot do anything else. Abdominal pregnancy, you have to done by a laparotomy for that. And this is what is important in obstetrics, though it's rare, but very often, very uncommon finding, we can find this particular case. Adnexal emergencies, some of the adnexal emergencies, particularly the torsion ovarian rupture, all these earlier also emergency was not tackled by laparoscopy. Now the laparoscopy scope has been broadened, but adnexal emergency can also be tackled with the laparotomy. Torsion subserous myoma, and particularly I can say the torsion subserous myoma, one experience I've got it during pregnancy. During pregnancy, the patient presented with acute pain, and uterus was almost around 26 weeks and pregnancy was 18 weeks, and the pain was not relieved, thinking that it could be red degeneration. We continued it, but the pain was rather aggravating, and there I explored it and did a laparotomy, again a midline incision, not a transverse incision, midline incision, because uterus was 18 weeks, and midline incision, and there was a torsion of the pedunculated subserous myoma, which I did it, and then subsequently patient. So these are some of the cases rarely we can find out, and there is a place for laparotomy for that. Post-op emergency, as for example, exploration, as I was telling it, patient was in shock, bleeding, internal hemorrhage. So post-op emergency, you have to save the life, and therefore the exploration has to be done. Sepsis, peritonitis, all these collection when there is a pus, and these are the cases where you have to go for laparotomy for that. And of course, the surgical emergency. Surgical emergency, you have to go for laparotomy, although laparoscopy has a place, but a rupture appendix, perforated appendix, or perforated gut, all these can be tackled with the laparotomy, particularly for that. And of course, the fetal surgery is now in experimental stage, and the fetal surgery can be done, and not with the endoscope. I think the fetal surgery, there are a lot of people who are trying with the endoscope, but majority, I think the fetal surgery started with the laparotomy and hysterotomy, and then doing a fetal surgery and closing it for that. Now coming to the laparotomy in spectrum in gynecology. This is an area where if you compare the laparotomy versus laparoscopy, the prevalence of laparotomy is gradually falling down all around the globe as the laparoscopy spectrum and horizon is increasing for that. But at the same time, don't have a dogma on this laparoscopic approach for that. In all cases, science doesn't believe in dogma. According to the particular need of the patient, it's not the mood of the surgeon that it should deal with that. And therefore, these are long list of laparotomy, indication of laparotomy in gynecology. So abdominal hysterectomy. People say that hysterectomy means laparoscopic hysterectomy, and there is a TLH surgeons which are there. I don't believe in that. I want that the gynecologist should be designated as a gynecologist. He or she should know laparoscopic procedure, he or she should know the vaginal procedure, and he or she should know the abdominal procedure also. Then only you can say that it is a complete gynecologist for that. So there is a place for abdominal hysterectomy. I will just show some of the videos for that. Abdominal myomectomy. Again, abdominal myomectomy, there is a scope for that. Ovarian tumors, pelvic endometriosis, cervicopexy for nulliparous prolapse, sacrocolpopexy, either a laparoscopic approach or you are opening, then you can fix it. Undiagnosed mass or a suspicious. This is one important area when the diagnosis is at a dilemma or a suspicious mass. Intra-abdominal collection, if there is a pus collection, if there is a blood collection, if there is a fecal peritonitis, that could be, there is no alternative for that. You have to do a laparotomy. And of course, last but not the least, a foreign body. Foreign body, like a missing tetra or leftover MUPS for that after surgery. You have done a cesarean section. You have done, this is not very uncommon. Till today also we are finding that. Although since last 20 years I'm preaching that don't use MUP in the abdomen in cesarean section. And in hysterectomy also, abdominal hysterectomy or other abdominal procedure also, MUP has to be, MUP is being used, and that a good counting and a very special, I think, warning before the peritoneum is being closed, the foreign body has to be there. But still there is a place. We find the foreign body. I see a couple of cases and how they are being tackled. These are all with laparotomy. I remember one case, a foreign body, it was diagnosed at that one of my student came and he done a cesarean section. I'll just convey this to you for all purpose benefit of others. And cesarean section has been done about 1.5 months back. Patient was having pain abdomen, but the bowel, bladder is everything is normal. Abdomen is soft, but tenderness at one point would be there, and sonography demonstrates a foreign body. I said that yes, it's a mop which is left over, and you must do it. And he was very keen for doing it laparoscopy. Sir, you do a laparoscopy and then do it for that. Then I told I'm not competent enough to deal with that. Basically, I do not want 6 weeks before the cesarean has been done and the foreign body has been there for last 6 weeks. It is not advisable to do for laparoscopy. It would have been a recent thing. I would have done a laparoscopic removal for that. If it is a 6-week-old, I think the major demerit is that the tetra has eroded the intestine, and tetra is likelihood that eroded the intestine and blocked that so that the bowel is normal. And once you remove the tetra, the rent will be there in the intestine, and you have to do a resection anastomosis. And therefore, I told no, don't do it. So one young, aggressive general surgeon came. He told that yes, I will do it. Then I told that yes, I will do it. Then he's a student of mine. I convinced him that don't do it. Start by laparotomy. But before I reached there, he started doing a laparoscopy. And when doing a laparoscopy, he was searching the tetra, got it, and then at last, when you find that the tetra has eroded the intestine and there are 4 to 5 rents in the intestine, then he converted. Then he says, sir, you are correct. I should not have done that. And these are the cases where there is a place for laparotomy. Post-op complications, as I have already told, post-op complications like bleeding, internal hemorrhage, you do it, or post-op complication of intestinal obstruction or something related to the GI system, you do it. Then conversion, another thing. The conversion while doing a laparoscopic surgery or even a vaginal hysterectomy or vaginal surgery. So a case where a vaginal hysterectomy is being done or laparoscopic hysterectomy is being done and you're not able to perform it and there is some difficulty at some point of time. Don't have the ego that I will do at any cost. It doesn't signify. It says that yes, if I convert it, it is reflecting on my efficiency. Don't think like that. There is no ego, sacrifice your ego and conversion. For the benefit of the patient, if at all there is any difficulty, you do a laparotomy and complete the procedure for that. This is remember, this is the golden rule for all people, even expert laparoscopic surgeon for that also. This is a message which I'm giving it. Then radical surgery. Of course, radical surgery, earlier the cancer cervix and cancer endometrium were the 2 surgeries which was being tackled by laparoscopy, and the rest of the surgery like ovarian and other surgeries are being tackled by laparotomy. Now, after the LSCC trial, which has condemned and it has compared the laparoscopy for laparoscopy versus laparotomy in a case of cancer cervix, has proved beyond doubt that the cancer cervix operation should be done by laparotomy, not by the laparoscopy procedure. But still the AAGL and other people are again reviewing this and finding out the skill is important. You cannot compare one surgeon with the other surgeon. And that could be possible in future. It might come. But in the present context, radical surgery, cancer endometrium, carcinoma endometrium is only permissible for that and only ethical or scientifically or rational, which is evidence-based for that. So therefore, radical surgery, Vardim operation and the ovarian tumor, malignancies, these are all by laparotomy. And these are the cases where you cannot give a small incision. Don't be conservative on the length of the incision. And you don't do a transverse, excepting the cancer cervix. You can do it with the transverse muscle cutting incision, or if it is ovarian, you have to do the para-aortic lymphadenectomy, and therefore it has to be extended upwards for that, and therefore midline incision with extension is preferred for that. Then there are some cases with the parietal pathology. There are parietal pathology, along with that pelvic pathology, that laparotomy has to be done. Parietal pathology, the hernia, the one of the common thing, hernia, abdominal incisional hernia, that's very important. Hernia, remember, the prevention is important. You, gynecologist, usually doesn't take care of a good closure technique and preventive steps for hernia. So very important is a prevention. Any surgery, any laparotomy you do take a special precaution of the hernia. Apart from it, the patient profile is also responsible. You can't help it. And these are the cases, the patient profile. You have taken a good, I think, vigilance and a good technique, meticulous technique, but the patient profile is there because of the intraabdominal pressure, the chronic cough, comorbidities, all these are leading to the hernia. And these are the cases when there's a hernia, you have to tackle that. And particularly if you have done the surgery, and for hernia, don't refer to the surgeon. I always tell my gynecologist. And incisional hernia, particularly in the lower level. On the upper level, you can send it to the surgeon. A gynecological pathology is there, a gynecological condition, and following hysterectomy or following sterilization, mini lap operation, or following the laparoscopic approach, or following the midline, or even a transverse, you yourself do it and learn to do it. It's not very difficult. I'll show some of the videos how to do it, the hernia. Scar endometriosis. There are some, majority of the scar endometriosis are limited to the parietal wall. They are not connected to the inside. But if at all they are connected to the inside, you have to do a laparotomy for that. But in a case where there is not connected and is superficial up till about the peritoneum level, then the opening of peritoneum is not necessary. But the same incision has to be given up to the level of the attachment for that. That's important. Divarication of recti, and this is again in a case where the many patients, they say simultaneous with the surgery in a previous divarication, you just oppose it and then do it in a subsequent surgery. Then you can do that procedure. Just is a very simple procedure. The rectus muscle apposition is necessary for that, and a good sheath closure is necessary. And abdominoplasty is the domain of the plastic surgeon or the surgeon. A gynecologist, I don't advise to do a abdominoplasty in the same sitting or isolated thing for that. Now, need for exploratory laparotomy. There is a need for exploratory. Suppose there is an exploratory laparotomy. Now, as we go, the diagnostic gadgets are improving. The need for exploratory laparotomy is coming down. So there is rarely a place where need for exploratory laparotomy just for diagnosis. There are all sophisticated gadgets available. The imaging science has developed to a considerable extent, so that exploratory laparotomy, there is no need. Virtually, rarely there is a place. Then, of course, the contraindications for minimal invasive surgery. Suppose some of the cases where minimal invasive surgery, the endoscopic procedure can be, laparoscopic approach can be possible, but there is a definite contraindications for the minimal invasive surgery in terms of surgery, in terms of anesthesia, because the patient profile, they are not fit for minimal invasive surgery. Those are the cases. Don't play with the life of the patient. You keep that. Yes, I will iterate safety first. And these are the cases where the laparotomy has to be done. A chronic COPD, an asthma, a very frail patient, very elderly patient where it's not, and anesthesia is not able to withstand the anesthesia. Those are the cases. Don't go for that. And even position, you are not able to do a position because of the orthopedic problem. So these are the cases you'd go for laparotomy, and there is a place for laparotomy and hysterectomy and other procedures for that. And others are the patient's preference. There are some patients who are very averse. They don't want laparoscopy. Patient's preference, patient want that, yes, please open up and do this case. Skill is important. The skill, it is acquired. The skill of laparoscopy is much more than the skill of laparotomy. So therefore, if you have a very expert laparoscopic surgeon, the limits are up to sky. So skill is important for that, and you should learn both the techniques, laparotomy as well as laparoscopy for that also. And lack of gadgets. If a lack of gadgets is there, you are practicing in a rural area, in a remote setting where you are aam aadmi ka doctor who, and you are serving the poor people. There is no gadgets. Economic regions are there. Then there is no place of doing a laparotomy and doing the procedure for that, and relieve the suffering of that particular patient for that. And of course, last is the surgery under local anesthesia. Till today also, I have seen people in periphery, in a peripheral hospital, in PSCs are doing surgery under local anesthesia. And I have my past experience of doing a number of cases of the local anesthesia, doing surgery under local anesthesia, where either the anesthesia is not available or the patient is an acute emergency where either ectopic pregnancy or rupture uterus. I have done several cases of that in the remote areas, not in the medical college, but here also in the medical college. Once I have seen that the anesthesia refused to give anesthesia. In a case of laparatory, in a case of rupture uterus, they refused to give anesthesia because of the condition of the patient. And I took a venture. I did under local anesthesia. I opened up and saved the life, and fortunately the life is saved for that. And that's the situation of spectrum of the laparotomy in gynecological practice for that. So, ladies and gentlemen, my viewers, the present status. What is the present status of laparotomy? It has not gone to graveyard. Remember this. It has not gone to graveyard. And don't think that it is a undignified thing to do a laparotomy. And don't think that those who are doing a laparoscopy, they are the greatest surgeons ever possible for that. Don't think in that way. And as a gynecologist, do the procedure for the need of the patient, not a mood of yourself for that. But therefore, selection of cases is important, no dogma in science, and of course, the basic factor is a meticulous technique, which is important for that. And again, I always say, my teachers were saying, every surgery is easy, every surgery is difficult. It is the surgeon who makes the surgery easy or difficult. It is you who will make the surgery easy or difficult, whatever may be the surgery. But for the benefit of the patient, you give an end result must be rewarding. And it's a safety first, minimal complications that should be targeted for that. Now, what should be the future prospects? I have analyzed what is the present status, and again emphasizing that there is a place for abdominal laparotomy for that. And everybody must be very skilled in having a good entry and a safe entry and a safe closure for that. So, future prospects, special glass for visualizing intraperitoneal structures. I always say, let me have a glass, special glass. I won't employ the ultrasound. I will wear the glass and see the under surface, the peritoneal, everything could be there when pathology is there. The no need, I don't send the patient to a radiologist. I will, as a gynecologist, I will see everything for that. Then the theory of minimizing and maximizing, and I said that laparoscopy, when we say there is Arjun's philosophy. Arjun say, mythology, we say that seeing the reflection of the water and says fire. And therefore the same thing, Hanuman's philosophy, minimizing and maximizing. Hanuman is small and Hanuman can be larger. And you enchant a mantra and the baby can be smaller, 3 kg could be split to 3 millimeter, and then maximizing to 3 kg also. And of course, the mad minds gives an innovation, enchanting a mantra, which is my dream in future, that future of surgery in 22nd century, what should be there? Enchant a mantra, surgery is over. And by the time surgeons are also over. And here, the new era of surgery coming soon in 21st century, that this is the OT in the present status, and this is the Bhava, which enchant a mantra, and all the diseases are being cured for that. So last is about the surgical wound healing. See, we are doing a lot of, we have covered about the incision, we have covered about the different tips and tricks, the techniques of the different incision and the indications of it. And remember one thing, think one thing. I was also thinking seriously, if the wound doesn't heal, what will be the fate of us? If the surgical wound doesn't heal, what will be the fate of surgery? What will be the fate of surgeons? What will be the fate of the patient? So therefore, healing, a miraculous phenomena by the Supreme Creator of life. And that's why we always say, we treat and he heals. And if healing is important, as a scientific point of view, let us analyze what are the factors in wound healing. There are 4 phases in wound healing. And surgical wound healing is different than the non-surgical wound. It's a clean cut wound, but whatever it may be, we're cutting the structures, and the structures must be opposed in a right manner as early as possible. So wound healing, there are 4 steps. First is hemostasis. Second is inflammation. Third is proliferation or repair. And fourth is maturation or remodeling. Hemostasis, remember, after giving an incision, immediately from the same time, the hemostasis starts within seconds or within minutes, maybe a fibrin block or a platelet block or some of the contractions of the muscles of the small vessels. So hemostasis is primary. Then comes the inflammation. Immediately you find an inflammation and inflammatory exudates come in view. The cytologies, there are some cellular thing which comes, there are some biochemical things which come, there are some enzymatic thing which comes, which is responsible for all the process of wound healing, starting from inflammation to the remodeling part for that. So the neutrophils come initially, then there comes the macrophage about 48 to 72 hours. Macrophages come, then the lymphocytes come, and they have an individual great functions in the process of proliferation, starting the proliferation and the repair after that procedure. And then the maturation occurs over time. So it takes a lot of time for maturation and complete wound healing for this strength. This is what I say, that hemostasis, there are two phases in hemostasis. First, there occurs clotting. After injury, these are the events which occurs. Clotting and vascular response. These two process starts right from the time of incision. And the clotting is immediately within 1 day, it is completed. Whereas the vascular response, maximum 3 days, it is completed for that. Then the process of inflammation starts, which starts right from the time of the injury or surgical wound. And therefore, it starts and continues up to about 4 weeks, 3 to 4 weeks, it continues the inflammatory process, the cytology, the cellular pathology, the extracellular phenomena, the enzymatic phenomena comes in play for that. And the next is a proliferative repair, where immediately the scar formation, early scar formation occurs within the first 4 weeks. And then subsequently, then after that, the scar formation occurs, epithelial healing occurs within 2 weeks, and then the contraction. These three processes occur simultaneously: scar formation, epithelial healing, and contraction, where the scar formation takes a longer time, then the epithelial healing, and then contraction for that. And of course, the last phase is maturation and remodeling. The scar remodeling occurs after the fourth week. After the 4th week, and it continues up to 12 months or even 18 months. And for the complete remodeling is completed by 18 to 24 months for that. And therefore, this is the physiology of wound healing basing on which is there. But there are some adversities. The patient profile is responsible for that. When the healing is impaired, either because of the metabolic diseases like diabetic mellitus, or because of the immunodeficiency states, or because of the comorbidities which is associated with it, that come up. Now, complication. Two major complications, I can say that yes, apart from the various other complications like internal hemorrhage or infection, the two major complications which occurs immediately is a dehiscence, and remote is the hernia. So immediately the dehiscence could be there. First is a superficial dehiscence up till the level of the skin and subcutaneous tissue. See this intact. This is superficial dehiscence. Then see this affected up till the level of the peritoneum, then this is incomplete dehiscence. And when the peritoneum is involved, it is a complete dehiscence for that. And when all these gut and intestine comes, is evisceration. This is called evisceration, and therefore the fourth step is evisceration or burst abdomen, which call it the burst abdomen. So dehiscence, according to the varieties, superficial, incomplete, complete, and the complete burst abdomen, this has to be tackled for that. And main thing is a prevention. So this is important. Prevention of these two important. Dehiscence occurs maximum within the 2 weeks, but hernia is occurs little late. And how to prevent and how to manage, you must know that. And prevention, normally we find that the patient profile is there, the doctor's profile is also there, the suture profile is also there. So therefore, these are all responsible. The technique is also responsible. The patient profile is also responsible for dehiscence and hernia for that. And you must be knowing in details about the tips and tricks of how the techniques is being done. And I have also pointed out some of the special areas where you take a precaution so that the prevention dehiscence will not be there, hernia will not be there. And fortunately, nowadays, the incidence of dehiscence and hernia has come down because of the skill of the surgeons and the suture material that is being used for that. And of course, if at all there is their management, the management is very, very, I think, specific depending on the type of dehiscence and the degree of hernia. And the dehiscence, if it is a superficial, I think the secondary suture can have it, but after the granulation tissue, healthy granulation tissue is there, then interfere. Otherwise, again, there will be a problem. And if it is a burst abdomen, you have to give the enforcement suture, the tensile strength will be there, and there you can use the proline, you can use the Vicryl, or with the tensile strength superimposed in series of suture which is there through and through mass closure, so that they can have a good I think restoration of the anatomy and doesn't restore the bowel to come out, and the dehiscence burst abdomen can be there. Along with that, give a broad spectrum antibiotic and post-operative period for that, and subsequently the abdominal binder. Now hernia again, the degree of hernia varies. A small hernia, asymptomatic hernia, doesn't need a surgery for that. A symptomatic hernia and a large hernia that needs a surgery, and therefore this hernia repair can be very well tackled by the gynecologist itself also. Again, I will say that you yourself do the hernia repair. Don't, you can take help of surgeons, there is not a problem for that. But you know the art of repair of the hernia yourself for that. Now, this is a case where we find, you see the abdomen here, there is a scar on the lateral angle, and there is a midline suprapubic scar which is there, and patient is coughing, and we find the bulge. The hernia is on the left lateral aspect and the lateral angle of the scar, and that is typical of the transverse scar. Normally, the transverse scar, we say that hernia is not seen, but this is a case where in the transverse scar also hernia is seen, and that is avoiding not to detect the triangle in the lateral triangle. I think that's important, and take care of that as a preventive methods. And if at all the hernia is there, I think if it is symptomatic and if it causes a problem, then resort to the repair, the anatomical repair with or without the mesh augmentation. You learn it, and here in this particular case, the J-shaped incision would be much more superior in tackling that, because the extent of the lesion is quite lateral to the lumbar region, and you can do that procedure for that. Now, coming to the second part, the clinical dilemmas for that. Situation 1. 45 years, para 2, perception of lump abdomen and pain 4 months. Normal cycle, para abdomen suprapubic mass 24 weeks. Sonography, uterus enlarged. Mixed echogenic mass right adnexa are fixed to the uterus. Collar Doppler, there is an increased vascularity. MRI is inconclusive, and therefore planned for laparotomy, frozen section, and then proceed. So we have suspected some abnormality for that, and therefore on laparatory finding, financial incision has been given. Uterus enlarged, both tubes and ovaries healthy. Degenerated myoma 15 centimeter diameter rising from the fundus towards right side. Minimal fluid in peritoneal cavity. Other abdominal organs normal. Peritoneal fluid cytology was taken. Frozen biopsy from the mass sent. Report came, no evidence of malignancy in peritoneal fluid cytology, and degenerated myoma on frozen section biopsy. So abdominal hysterectomy with the BSO was performed, postoperatively uneventful. So this is a case where laparotomy is mandatory, and because the initial diagnostic gadgets were inconclusive, and the sonography shows that yes, there is increased vascularity, collar Doppler, and the mass is really a degenerated mass. But in opening, we find a pedunculated subserous myoma, degenerated myoma arising from the fundus. Both the tubes and ovaries are normal, and that frozen section confirm it. When looking also, it looks like a malignancy, and therefore frozen section has confirmed that. And then the usual procedure is not a difficult procedure. You can do the hysterectomy with the bilateral salping oophorectomy, and again send the biopsy, again repeat the biopsy for that. So this is one of the example where a little suspicion, you take the advantage of the frozen section for that. So the message is, place of laparotomy in suspicious mass. Don't do for a laparoscopic procedure. Imprint, smear, frozen section biopsy, and important elements, I think, adjunct to the surgical decision making for that. Situation 2, 40 years, para 1, LACS, menorrhagic cycle with dysmenorrhea, suprapubic mass of 18 weeks, sonographic evidence of myoma uterus and chocolate cyst. Both planned for abdominal hysterectomy. Incision fun and still, uterus enlarged with myoma uterus, POD obliterated, both ovaries and tubes either into POD, rectosigmoid either into posterior surface of uterus, hysterectomy with the BSO done on eventful postpartum post-operative period. So now the incision again is a transverse incision which is being given as usual. You have seen, I have already demonstrated how to do it, and all with electrosurgical procedure. There is a case of previous cesarean section. So because the fibrosis, there could be a little difficulty in the incising, and the bleeding is less also. And always this point or the finger, the electrosurgical pencil helps us in a very better way for that. Same thing, we do that and reflect the posterior, the inferior as well as the superior part, separated from the muscle, rectus muscle. This completely separated, and then we can enter into it for the peritoneum for that. Now the rectus sheath, you can see the rectus sheath because there is a previous surgery, how the rectus sheath is adherent to the peritoneum, and with a little small nick, you go and separate this, and then you can find that yes, I have separated that, but still the muscle is attached to the underlying surface, and the muscle, you just catch hold of this, and peritoneum is visible, separate it from the muscle, peritoneum, catch hold of the peritoneum at the higher level, so that the damage to the peritoneum, the bladder is not there, and cut it. And once you nick it, and don't cut it with the cautery. Remember, peritoneum has to be cut with the scissor, because the cautery, if at all there is a bowel is there, then there will be a problem. And here we find a myoma of about 18 week size with dense adhesions in the POD, and the whole of the POD is fixed to rectosigmoid, is fixed to the posterior surface of the uterus. And the same procedure, either by suture or with sutureless, whatever is important, whatever is suiting well, we are fitting with that. And I always do the sutureless with the laparotomy also. We do that accepting the closure of the vault and fixation, and then closing of the abdomen. Otherwise, everything is done with the sutureless technique, with the bipolar vessel sealer, the upper pedicle, the uterine, and the Mecken rod. And but very, very careful dissection of the POD has to be done in a rectosigmoid. In this particular case, it is relatively easier because the rectosigmoid is adherent to the lower part. At times, what happens, you are not able to see the whole of the gut is adherent to the uterus, and that causes a lot of problem. But whatever it may be, go close to the uterus, whether suture or sutureless, do a hysterectomy in that particular case, and complete the procedure for that. So myoma with endometriosis is not uncommon. Place of laparotomy is there in this case. Now, think whether this case could be tackled with a laparoscopic approach. It's possible. It's possible with experts, but not with everybody for that. So you assess your own limit and do the procedure. And there is a risk to the rectosigmoid, and there is a risk to the damage to the ureter. And these are the cases where why unnecessarily show your surgical excellence at the cost of the patient. And you do it, and do a rectal injury, sigmoid injury, call the gastrointestinal surgeon, then repairs it and all that. There is no use of showing this excellence to that. And therefore, I say that these are the cases where there is a place for the laparotomy and abdominal hysterectomy. So abdominal hysterectomy has a place. Now situation 3, 45 years, para 2, abdominopelvic mass of 28 weeks, sonographic evidence of myoma uterus, and there is a broad ligament myoma planned for abdominal hysterectomy. This is because of the size, because of the location of the broad ligament myoma by ultrasound, we have decided for doing a abdominal hysterectomy. Incision is again, we can go it longitudinal, midline is much more easier, preferable, because the size is 28 weeks. But I'm always in favor of the transverse incision and financial incision. And even without muscle cutting also, you can deliver it. It's a little difficult, but the patient surgeon's inconvenience is directly related to the convenience of the patient. That's my belief. And the large broad ligament myoma and the fine myomectomy, then in this case, first do a myomectomy, debulk the case, and then do a hysterectomy, and is an uneventful post-op period. So this is, see how big is the mass at 28, 30 weeks size. Again, after marking this particular case, which I was saying, 3 centimeters on either side, and then little carved incision you give it, and then with a small incision also you can do it, because you can do a myomectomy and deliver the whole of the uterus after that. So this is the case where again layer closure, layer opening has to be done, and this is entry into the abdominal cavity, and then you find that there's a large mass. So it helps either a vacuum or a myoma screw helps in that delivering of the large mass for that. So these are the cases it can be delivered. So the length of the incision, the site of the incision is not a problem unless it is a malignancy. So it's a benign. If you find that it's a benign mass, I think it can be done by a transverse incision, but little difficulty will be there in delivering the uterus, but ultimately it pays well. So this is a large myoma of the broad ligament, right side broad ligament, and this particular case, I don't advise that it is to go for a laparoscopic procedure for that. And this is a case where the myoma, such a big myoma, a broad ligament myoma, you enucleate that, and after the enucleation of the myoma, complete enucleation of the myoma, you can debulk it, you can find out a good reasonable size of the uterus, and then do the rest of the procedure in hysterectomy as usual. So this is a case where there is a place for the laparotomy for that, and this is absolutely a benign case. And once the tumor is removed, you can see that how easy is a surgery for that. This adds a difficulty I think if you do a myomectomy, the advantage is that the chances of ureteric injury is less. You can find that either a true broad ligament myoma or a false broad ligament myoma, whichever is there, the advantage of the ureter is safe. Now you can see the normal size uterus on the left side, where I have removed the myoma and then done the same procedure either by sutureless device or by suture, and completing the procedure for that. So this is one of the example where there is a place for a laparotomy and abdominal hysterectomy. So the abdominal hysterectomy is also there is a place, and one should cannot say that yes, you always do with laparoscopy and all that. An expert laparoscopic surgeon can do the procedure, that I believe, but there is a limit to that. And in a case, such case like 28, 30 week size uterus, I think preferably I don't like to do that by laparoscopy. And here we do the procedure by the open method, laparotomy. So the broad ligament myoma of large size, there is a place for abdominal root. Precaution for ureter is needed. Myomectomy followed by hysterectomy should be the principle, and it facilitates surgery and avoid complication for that. 42 years, multiple myoma, abdominal lump, 30 weeks, planned for abdominal hysterectomy, and 30 weeks abdominal lump, multiple myoma. It's a benign, and incision is again fun and still. It varies. You can give a longitudinal also, but my perception is on always again and fun and still. Multiple subserous intramural myomas, ovaries are normal, hysterectomy done, and uneventful patient. Now you see a 30-week size uterus, again a transverse incision I have given, and same procedure we do it. There is a little difficulty in delivering the large size uterus, but there are ways you do it. And in extreme cases, when you are not able to do it, you do a muscle cutting. But again, I am not in preference to the muscle cutting. Incision with the muscle splitting is much more better, because the morbidity increases if you go for a muscle cutting incision for that. So these are the cases where the again go hemostasis, then rectus sheath, and again the same procedure as we go the laparotomy by a fun and still procedure. Let it be a gynecology, let it be an obstetric, is all same. And again, I have told the tips and tricks and techniques and special areas where you must be very careful for that. But remember, the hemostasis is absolutely important in all cases. Hemostasis to the surgeon, oxygen support to the anesthetist, and intraoperative period is not a problem for that. So here, just touch with the electrosurgery and this. And always remember that it's always cutting the peritoneum with the seizure, not with the electrosurgical procedure. And here we find a myoma screw helps in delivering the uterus. Even big size uterus, we can deliver it. And we can use the vacuum cup also with that. But myoma screw along with the vacuum cup is really beneficial. This is a large subserous myoma, and along with that, the multiple myoma. There are multiple myomas which is there, and such large size. I think it's better that you do a laparotomy rather than doing a laparoscopic approach and exhibiting your surgical expertise or excellence at the cost of the patient for that. There are a lot of complications, and the timing will be more. The anesthesia exposure will be more, and a lot of other complications of damage to the ureter and other structures will be more for that. So these are the cases where you can go for that. And this is a round ligament. Then again, the infundibulopelvic pelvic ligament. I've gone to the vessel sealer, and these are the cases where there is an indication for that. So size of the mass, an indication for abdominal hysterectomy, another indication. Incision, fun and still versus midline. It's an individual choice, but preferred is transverse. If you are doing it, the preferred is transverse. This is another case, 39 years, menorrhagic cycle with progressive dysmenorrhea and pain abdomen off and on for 2 years. Known case of pelvic endometriosis, lap surgery twice, para 1, cesarean section 12 years ago. And for this pain, she was having the medical management, tons and tons of progestrogens, and leuprolide acetate has been given and attempted. At last decided for laparotomy. So attempted laparotomy and hysterectomy elsewhere, but it failed surgery. The patient presented to me with a history that 1 month back I had done a laparotomy and open and close, because they told that everything is pasted. I'm not able to see. It is not possible. And they closed it and then sent to me. And on examination, I find suprapubic mass 16 weeks, transverse scar, sonography is a diffuse adenomyosis. And therefore, I planned for abdominal hysterectomy after 2 months. I gave a period of another 4 weeks, and 2 months, after 2 months of surgery, primary surgery, I decided that I will do for this again re-exploration. And again, I was thinking that yes, I will take help of surgeon's friend if at all is necessary. And these are the cases you also is wise to take the help of the surgeons if at all there is a problem. You make this also one of the case where surgical assistance is necessary. And incision is fun and still, and on examination I find only small portion of the fundus is visualized. Extensive adhesion all around the uterus with omentum, gut, and rectosigmoid. Hysterectomy was performed uneventful postoperative period. You see, this is the case. We started with that. There is a cesarean section scar, and there is another scar of the failed attempt for that. So 2 scars and 2 times laparoscopic surgery has been done for that. So extent of the lesion you must find, and you can see how the muscle is fixed to that rectus sheath, and here the muscle is also fixed to the peritoneum. Here is the technique I was just telling. Lift the peritoneum and just dissect with the help of the seizure. Separate it from the muscle, separate the muscle from the peritoneum, then enter it. I find only the small portion of the fundus is visible. So that portion, I put a myoma screw and see, nothing was visible. Everything was pasted with that. A blunt dissection and careful dissection, particularly on the gut. The chances of gut injury is much more common here and more so on the posterior aspect. But the traction with the myoma screw helps in a better way in not only dissection but really finding a cleavage for that also. So these type of cases I want that one should take a credit not by doing a difficult laparoscopic surgery, but these type of cases they should learn to do, particularly without any complications to the rectosigmoid and without the complications of any vital structures. They should do it, then nothing like it. And the medium level gynecologist should practice. I always tell my senior assistant professor that be exposed to these type of cases, your confidence level will be increased for that. And these are the cases where you can do that. Now, something has been described, this particular case. Can it be done with the retroperitoneal approach? Retroperitoneally, everything is so, anatomy is distorted that you can't find the retroperitoneal approach for that. If there is a visibility on a particular aspect, then the other aspect you start retroperitoneally and dissect it. But these are the cases, even retroperitoneally you cannot do it, but there is a risk of the rectosigmoid or other. See, all around there is a attached for that, but this traction helps in a better way in dissection for that. And once you go slowly identifying the structure, and ultimately you find that the hysterectomy is being completed without any complications for that. So this is how these difficult cases can be tackled very well with that. And once you identify one, slowly you go with the round ligament and with this is the tube and the ovary, which can be grasped and can be separated from the gut, and you separate it, and then same procedure you do it with the catch hold of the round ligament, separate it, and then go. So here we don't find anything, and therefore the extraperitoneal has least value in this particular case, but a careful dissection of the posterior part is much more important. That posterior part and the adnexa to the gut is much more important for that. And many times we find a difficulty, so that the surgeons can come in a great will for that. So once you go stepwise and gently, slowly, you go and more close to the uterus. The basic essential theme, you go closer to the uterus, and then this saves a very good complication-free anesthesia for that. And that is important, more so in the posterior aspect with the blind dissection, with the finger dissection. Finger is the best dissector ever possible, and always closer to the uterus. That is the main philosophy I always tell. And as we go down and down, the uterus will come up and up, and the rectosigmoid will be separated. Laterally, we find that the adnexa is separated. The uterine, once the uterine is done, this is the uterine, which I have holding with the vessel sealer, and then gradually go closer to the uterus, and everything, all structures will be completed for that. So these are all challenging situations and challenging surgery, particularly in the previous history of surgery. Endometriosis is really a difficult surgery, which is where, and this is the area where the uterovesical fold of peritoneum. Again, that could be a problem because there is a history of previous cesarean. So bladder dissection is a problem. And here is the posterior aspect. You can see the rectosigmoid and separate it gently and with the blind, with the blunt, as well as with the sharp dissection under vision, you just dissect it and complete the procedure for that. So these are the cases which is not uncommon, but it needs a lot of surgical skill and challenge. And these are the cases, even we do the laparotomy also, that creates a lot of problem. Don't think that laparotomy is easier, always easier, and do the laparoscopic surgery, but at times you find that laparotomy is also very difficult for that. And these are the cases which is very, very difficult to tackle with the laparoscopic approach for that, although it depends on the expert and skill and the gadgets which is there. But invariably, these are the cases which land in complications of either a GI or a ureteric thing for that. If at all you are going for laparoscopy, ureteric glow should be there. You have to do a ureteric catheterization prior to the surgery, and then ask your the colorectal surgeon to have backup, and then do the procedure for that. But therefore, I say that an ordinary gynecologist with little experience can do this procedure with the abdominal approach and complete the procedure with a uneventful recovery. And this patient has a very good post-operative period, and discharged after 3-4 days. 4 days after that is discharged. The bowel returned after 48 hours, and miraculously the patient was very happy, and then the pain was really relief for that. So now this is not a problem. Now they ultimately the problem areas is over. Now we are going for the rectus, the mechanoids and the uterosacral. This is the newer version of the Martin which I'm using it. I've designed that equipment, and it's a cutting and mechanical cut, and the vessel sealer with the mechanical cut like a pistol, and it runs very well, and it is very safe for that also. And it's very difficult to put a series of sutures here, and therefore the sutures vessel sealer device helps to a great extent in the dissection, and ultimately whole thing can be performed very well for that. And now after the mechanoid and uterosacral, you go and see the vault and the angle, and then the same instrument can be used for the vaginal vault thing. And remember, these are the cases we always close to the uterus. That's why I told that again, you close to the uterus here and find out the lateral extent. And this is the uterosacral mechanoids which is there. The whole anatomy is distorted because of the disease, because of the pathology of endometriosis. Usually it is distorted, but ultimately, if we are very, very meticulous, this challenging surgery can be performed very well. There is not a great job for that, and everybody should learn the technique, and there are some basic tips and tricks. That's why I wanted to show this type of things and transfer the knowledge for that. And now I find that yes, the vault is open now, and after that the vault is open, and then subsequently these are the bleeding points which again needs a coagulation for that. And now the vault is open, and I'm just removing the uterus, the last part, and this is the part which is in the angle of the vault, and again very close, because the ureter is going to be very close to this structure, and therefore you must be very, very careful not only about the rectosigmoid but the ureter in the lateral part for that. And this instrument helps me very well, because it just coagulates. Vessel sealer is there, as well as the mechanical cut is there, and you can use the shear also for that. But this appears that is really good to tackle this instrument, because it's very handy, and we can do the job very with a less of bleeding for that. And all around you just separate it and go and tackle the vagina open, and then do the procedure, and the whole of the thing can be very well done with that. So these are some of the cases where we see and where we are convinced that abdominal hysterectomy has not gone into the graveyards. It is still there. Now you can see the vault is open, and with that instrument you can open the vagina. With the hemostasis it can open it and finish the procedure for that. And this is the vault vagina which is being hold it, and from one angle to the other you apply the same instrument and open this vagina. And of course the closure will be last. At this step we require the help of the suture. Otherwise, up till this part No suture is required for that. And this completes the procedure of the total hysterectomy at the same sitting with a very confident manner. So these are the cases where the message is situation is not uncommon. Laparotomy is the preferred choice. Preventive surgery and meticulous technique is essential and may require help from surgeons, as I told. But this is a challenging surgery. And about the laparoscopy, this particular case, I think this carries a lot of risk and challenge to the laparoscopy for that. This is another 42 years unmarried, history of childhood, polio, deformed legs. I was surprised. I feel pity on this patient, unmarried, 42 years, deformed legs, poliomyelitis, ankylosis of hip and knees. The position is important. For whole years, for last 37 years, the patient was with the disordered limbs because he was having a childhood polio, and then subsequently developed deformed legs and ankylosis of the hip and knees with menorrhagic cycle, sonographic evidence of myoma uterus. And it's not responding to medical management, and therefore it's a plan for hysterectomy. And the preferred route, I confidently say that it's abdominal, because the positioning is a great concern. Incision is again, I've given Phanencil, abdominal hysterectomy done, uneventful intra-op and post-op period. And I don't repent that why I've done a vaginal, why I've done a abdominal hysterectomy, because I believe that you should do everything. You should know about abdominal, you should know about vaginal, you should know about the laparoscopic approach also. So these are the cases where you see that the position is an important factor, and with that position you have to do a laparotomy. You cannot do a laparoscopic approach for that. A large myoma can be delivered with that. This is just to show that this is one of the indication of laparotomy, not of laparoscopy for that. This is a contraindication. So positioning in surgery is an important part for selecting the route. Definite place for laparotomy. There is no disagreement for that. So therefore, abdominal hysterectomy has not gone into graveyard. You just remember, these are the cases where hysterectomy is necessary abdominally. This is another case, 40 years, para-1 LSAS, progressive dysmenorrhea, and cyclic pain over scar area. This suggests the scar endometriosis. On examination, we find the tender mass center in the center of the scar, but uterus was 10 weeks, firm, restricted mobility. Sonography, adenomyosis uterus with evidence of scar endometriosis. So therefore, I wanted to tackle both by doing a laparotomy. It cannot do by laparoscopy. So both I decided to do a scar endometriosis excision first, and then to open the abdomen and plan for laparotomy. I give a suprapubic transverse incision, enucleation of scar endometriosis is done, but unfortunately, a typical case is there. The score, normally the scar is endometriosis is fixed up to the sheath or muscle, or up to the, at best, up to the fossa. But here, on dissection, I found that the whole of this scar endometriosis is fixed to the fundus of the uterus. There is extensive adhesion and POD, rectosigmoid and adnex are densely adherent, and therefore I wanted to do separately EG surgery, but this is a very difficult surgery from the beginning. So there is a scar, I excised it because the previous scar is there. I excised the scar, then enter into it the area, and wide dissection is necessary in the center of the part, because there is a scar endometriosis. Unless you do a wide dissection, again the chance of recurrence will be there. So therefore, wide dissection is there, enucleation of the scar, and healthy tissues, the rectus sheath, healthy tissue, up till the healthy tissue, and all around. I wanted to dissect it all around, and then after dissection, I could find that yes, it is not detaching from the muscle or from the sheath. So therefore, I cut the sheath and dissected it, and find that the whole scar is adherent to the abdominal, the fundus of the uterus. So this is a very important case where this is a necessity of a wide scar, wide excision, because the healthy tissue, if small amount of endometrial tissue is there is again going to again recurrence will be there. So therefore, I went all around. This is the lower part, this is the upper part, and dissection of all around will be there. Then the rectus sheath will be there, and you can find it. It's a very big scar endometriotic lesion, which is not being manifested or shown by the sonography. Sonography size is not detecting, and sonography doesn't detect that it is fixed to the uterus for that. So this is the healthy rectus sheath. I've dissected all around for that, separated, because at that point I'll give an incision and separate it and find it out for that. So this is one of the example where a typical case can occur. Normally the scar and endometriosis is limited in the parietal area, but here I find a difference in that. And because I decided that it's a case of adenomyosis, I will do an excision and then subsequently enter into the abdominal cavity and then do a hysterectomy for that. But this is the unusual case which is there, and because of that there is a lot of wide excision, there is a lot of bleeding, and here this is the rectus sheath, and the healthy part I excised it, and then I entered into the peritoneal cavity. Can you see that now the rectus sheath is being dissected from all around, and then the muscle is there. Then I could find that yes, I will enter into the abdominal cavity for that. So till that time I didn't know that this was a scar endometriosis which is either into the fundus of the uterus. I dissected all around, and then after that, while cutting it, then I found that yes, it is the fundus which is there, and this is the fundus which is attached to the scar endometriosis nodule, and this one is the uterus which is being seen, and therefore these are the cases where a typical case can present with that, and you must be very meticulous in doing that procedure for that. And therefore this is only laparotomy can help. In no laparoscopic expertise in endoscopic surgeon, there is no place for tackling this particular case of scar endometriosis along with the uterus which is there in the adenomyosis for that. Now you find that the whole scar is adherent to the uterus here, and therefore I just enucleated this and then subsequently did a hysterectomy for that. This is again a case where this is a scar endometriosis, where on the angle you find, and there's a J-shaped incision. I have given a J-shaped incision just to demonstrate how the J-shaped incision is being given. There's again a scar endometriosis which is superficial for that, but there is a to the one of the extent we don't want to a complete length, limiting the length of the incision. I don't want to extend it much more, but more laterally, and exposure to the lateral angle of the scar is there. And then subsequently again the same procedure, I just have a wide excision and excise the endometriotic area for that. So here the endometriotic, when I do the dissection, this is the endometric nodule, and this is a tissue which is fixed to the rectus muscle, rectus sheath. And once you go for the rectus sheath, you just cut the rectus sheath, and then the whole of the scar can be visible, and underlying it is absolutely free. And sonography also doesn't reveal any intra-abdominal pathology. The uterus and ovaries are absolutely normal, and this can be very well enucleated with, of course, with hemostasis is to be maintained for that, because there is a lot of small tweaks which has to be tackled with the electrosurgical device, both with the unipolar as well as the bipolar. You can use it, but this cutting is always with the unipolar because the cutting current is necessary for that, and whole thing can be delivered completely with the safety. And these are the cases where even if we cannot call it as a laparotomy, laparotomy means you enter into the cavity, it is in the parietal region, but I have shown purposefully. The earlier case, it was a laparotomy. It is gone and opened the abdominal cavity, and then the uterus hysterectomy has been performed for that. This is a case where it is a lateral angle, and these are the cases where it is attached to the superficial layer and being confined to the parietal wall, and you just have a wide excision and then complete the procedure and suture the rectus sheath for that. And if at all there is a wide apposition and you cannot find the suture, the rectus sheath in a position, you can augment with the mesh plastic for that. But ultimately this is not necessary, and whole thing you can see that how it is beautifully dissected all around, and this can be done very meticulously for that. And this is the rectus sheath and all around the healthy tissue, and then these are the vessels which needs a coagulation, and this is just above the muscle. Can you see that this is just above the muscle? And after the end of the procedure, you can clearly visualize that the scar endometriosis is superficial inside in the peritoneal layer, and therefore this doesn't need to go entry into the abdominal cavity, and but this is not in true sense a laparotomy, but a parietal lesion doing the same incision, accepting entry into the abdomen. This is attached to the muscle. Can you see that this is attached to the muscle, and the whole area can be really segregated, and once you dissect it, you can completely find that this is attached to the muscle, and the inner surface is absolutely normal. There is no need of opening the peritoneal cavity, and therefore this completes the procedure, and then subsequently you have a interrupted suture or a continuous suture, and then find that this is a clean-cut case of endometriosis, scar endometriosis. The size was not earlier by ultrasound, it was thought to be a 3 centimeter mass, but it's found that it's absolutely 3 times more than this. And you see, therefore, a very good wide excision is necessary for the treatment, for the modality for that. This is again a case where we see that this is a case of umbilical endometriosis. Again, an incision. Earlier it was a J-shaped incision. This was a umbilical incision, peri-umbilical incision, transverse incision peri-umbilically, and we had to do a paniculectomy and then repair with the greatest strength, so that in future it doesn't have a hernia. So these are the 2 cases where we find that the umbilical endometriosis, this paniculectomy is essential for that. We cannot keep the normal umbilicus for that. If it is the hernia, para-umbilical hernia, we can transport the umbilicus, reconstitute the umbilicus, and do the reconstruction. But here we don't want. But before that, a laparoscopy is done to the extent of the lesion here, and therefore we know that the extent of the lesion is not there inside, and then we clearly did this operation for that. And it's very easy, it's not very difficult surgery. As a gynecologist also, you can do it. You don't need the help of general surgeons also. And remember, after doing a paniculectomy and excision, the whole thing, the layer closure is important. The closure is important with the suture material. That is important. So everything is whole. Now the whole thing is umbilical endometriosis is delivered. Then you see the margins. You see the margins, and see the whole of the area is delivered with the healthy tissues. And then this is the margin, the peritoneum, then the sheath, and the rectus muscle. Everything is there. But here a layered closure is also a mass closure is also enough, rather than the layered closure for that. But the suture material should be absolutely good. Either you use a Prolene, or I use always a PDS or the Vicryl for that. And this is another case where we have done the same thing, excision of that, and procedure is completed. So the message, scar endometriosis is not uncommon. A typical case is fixed to the uterus, meticulous wide excision necessary to prevent recurrence for that. Then another case, 38 years, para 2, both LSES, presented with incisional hernia. Plan for repair, incision suprapubic transverse. I say always, learn to do a hernia repair yourself. And it's not a difficult job. Incision suprapubic transverse incision, layered dissection, large defect identified, normal abdominopelvic organs, anatomical repair done. And along with, because there's a large defect, the dissection is important. It's large or small, anatomical dissection is important. That's because you have a mess, you put it, I think the recurrence will be there. I don't believe in this. So anatomical repair with or without augmentation with the mesh is important. And here of augmentation, Romovac drain is given on eventful postpartum period. So this is a case where you find a clearly scar in the incisional hernia, and the ultrasound also shows that the uterus, ovary, and everything is normal. And you see the extent of the hernia is so wide that you can do that. But remember, while using this cautery at that place, it is very, very, very important precaution that you go more close to the skin. So because the area could be adherent to the internal, the bowel could be adherent closely. So just go closer to the skin area. Don't go deeper area, so that you are likely that you can be touch the intestine for that. And therefore, either this cautery or with the um, knife or scissor, you can dissect it. Now you can find the hernial sac. The hernial sac is multiple hernial sac is there. Now in the inside there is a hernial sac. On the right side there is another pouch which is there for that. And therefore we must excise everything. And this is a hernia which is being repaired for that. So very well dissected layer closure is necessary for that. And here there is a, I have gone for extension. So therefore is a longitudinal incision and extension is there. Again, and here you find the multiple hernial sac is there. So here I want to know, I want to this is the area where the peritoneum is attached, and above it you can find another hole, another pouch is there, and we must remove this additional the hernial pouch for that. And therefore you go very meticulously with the dissection part. So dissection is much more important than in hernia than the mesoplasty and all that. So on either side you just dissect it, the peritoneum separately and then the muscle separately, and oppose the peritoneum, oppose the muscle, and the sheath must be very, very carefully opposed with the suture. Don't use the catgut. Catgut cannot solve the purpose. You use always the PDS or the Vicryl. You use it. You can use the Prolene, but Prolene I don't like. But Prolene has a place also in the rectus sheath. But I closed it with the Vicryl and then superimposed with the mace also. Here is a so large defect and so big a defect that I did it. So this is another pouch, another area or hernial sac. There are multiple hernial sacs in the peritoneal, in the parietal wall. There are 3-4 areas where I just obliterate the hernial sac. That's important. So wide part dissection of the layer, then the hernial sac, identification of the hernial sac, and removal, and then apposition in the layer with the proper suture material is the key for hernia repair for that. And therefore, this particular case is just excess fibrous tissue. I just removed it, and then this is the area where the rectus sheath is dissected from the peritoneal, the subcutaneous tissue, so that the layer closure will be much more better. You can do either a mass closure or individually, but I always prefer I think layer closure rather than mass. So this muscle can be seen. Muscle can be seen. The dissection of the muscle from the peritoneum. You just see it, separate it, so that I can close the muscle also, oppose the muscle along with the and in a layer method as we do it, and so that the position is much more better for that. So this is how you just dissect. So importance of dissection, what I mean to say, that importance of dissection is very, very there, particularly in a hernia, and when we are going for the anatomical repair for that. So after the dissection and removal of the fibrous tissue, and because you can see the uterus is normal, and there is no evidence. You inspect when you are going for a laparotomy, you have to inspect the uterus, ovaries, and other thing. Then close the peritoneum and the rectus sheath and everything. Again with the Vicryl, I'm using the Vicryl, and continuous suture, continuous locking, continuous simple is the peritoneum, but continuous locking sutures in the Vicryl, in this rectus sheath. And these are the cases where it gives a very good result if you do it. And remember, as a gynecologist, you don't create hernia. The surgeons criticize us that gynecologists create hernia, we repair hernia. No, I always say that gynecologists create, even if they create hernia, they will repair themselves. You don't send the to surgeons for that. Of course, there are many of our faculties where the gynecologist are the wife and the surgeon is the husband. They took over and dominate and do that. Even with them also, I advise that don't do it, do yourself under supervision of your husband. That's all right. So this is the muscle which I had separated, a position of the muscle in layer, and then subsequently this. And these are the cases because there is a wide dissection and a large area. This needs a mesh augmentation and with always a drain. I always put a Ramovac drain here so that the collection is not there, and this gives a better postoperative recovery and post-operative, really the hernia, and the people can, the person come for post-op checkup, and I'm so happy that the patient is very well. And for last so many years, he was with all the abdominal binder and all this discomfort, and everything is popping out. This is being relieved for that. So this is a Romovac drain which I have given, and then subsequently the same technique I use it. The angle you use it particularly when you're giving a, this is a longitudinal long incision, but in transverse it's mandatory to put a angle, your angle first. So this is how you give the continuous running suture with the Vicryl, and then subsequently after that you put a, this is the Romobactam which I have given below the seed, and this is the mesh augmentation which I'm giving it, mesh augmentation, and with the again drain above we can do that. So incisional hernia is not uncommon. Preventive steps in primary surgery is important. Surgical repair is essential. Still I give importance on prevention. Domain, gynecologist or surgeon, you people decide. After I demonstrated everything, you are the best judge whether the domain of gynecologist or surgeon. Meticulous dissection is essential. Anatomical repair gives good result. Mesh augmentation in selected cases, but laparoscopic approach an alternative. But I don't know whether the nowadays the good mesh is there. They can go for a the approach for that. This is another case where there's a laparoscopic surgery has been done, and there's a port hernia. This is a port hernia where laparoscopically I find I confirm that there is a momentum which is adherent to the port, and therefore this particular case I always prefer. Prevention is always, if you are giving more than 10 millimeter port, you have to go close the port site, and the port closure is necessary for that. So this is a consequence of not giving a port closure after the more than 10 millimeter, or you are using the morcellator, you must give it the port closure needle for that. Port closure suture, at least one suture is enough for that, and therefore this is a case where it is being released first, and then subsequently the other things cannot be done by laparoscopic approach, provided you are going for the mesh. Mesh has got a certain demerits of that, and after absolutely visualizing everything, then we go for the open thing, and here I can put a suture there, but the effect is not there. We can find a big sac there, and the sac should be widely excised and completely repaired from the parietal wall. So I decided that yes, it's not wise to put a suture only on that, because I can put a suture on the peritoneum, but the seed, I think the main strength is with the seed, and that is not possible. So mesh is all right, we can put a mesh, but here therefore with again a small grid, the incision, small incision, J-shaped incision, I have put that this is the area, the sac I have decided, I have found the sac here, and the opening is very small, and you can close this with the layer technique with that, and the finger, just a finger is there, and you can close this from above, and hardly it's a minimal operation for that. This is 22 years unmarried girl, abdominal discomfort since 1 month, normal cycle. It's a farm mass 32 weeks, sonography myoma uterus, color Doppler normal, MRI evidence of myoma uterus, plan for abdominal myomectomy. Incision again, fun and still, I am always in prefer, but midline can be given. Delivery of the uterus is a big problem, hemostasis, removal of myoma, and hemostatic closure. So this is a case where you will see the 32 week size uterus and myoma. Again, I'm giving a fun and still little longer incision, but same thing is there. I've given that, and again with the hemostasis, with that taking care of that particular bleeding, and the rectus muscle separated widely, then the peritoneum is opened, and then after that the delivery becomes a great problem. Again, myoma screw can be of help for me, and the suction, I mean the vacuum cup can be of help to me, but here the myoma screw, I've used it and taking precaution that I identify that the tubes and ovaries are not close to it, and I find that this is a big myoma which is there with the again another myoma screw, or another with the finger, or with the seizure, you can reach the top and deliver it, the whole myoma, and come out of that. So the question comes that these are the cases where the option is easier is a midline incision. Easier is a midline incision, but I believe that the surgeon's inconvenience is directly proportional to the convenience of the patient. And you find that there is a beautiful large subserous myoma arising from the fundus and a pedunculate myoma, and along with it there is another small myomas in the anterior part and the posterior part for that. Otherwise, both tubes and ovaries are healthy, and because of the multiple myoma and the tube, you can see the left tube adherent to the myoma. You must be very, very meticulous in giving an incision and separating this, which is at times very difficult in laparoscopy for that. So you identify where is the site, give again a vasopressin, and then do the surgery and take a precaution that it will higher up in the cornu so that the tube is not going to be clamped for that. So preservation of the tubal anatomy for future reproductive outcome is necessary, and accordingly there is a place for an abdominal myomectomy rather than the laparoscopic myomectomy, even if you have a marcelator for that. So is again another case where a big myoma is there, a solitary myoma on the interior wall, and here we can do that. Again, vasopressin can be given, and you can see clearly the anatomy of the uterus with the normal tube and ovary on either side, and a longitudinal incision or a transverse incision. A choice is yours, and but the main thing is that a good cleavage should be done, and a proper entry to the cleavage is beneficial for that. So this is how you do a myomectomy, and closure is a very important thing. This is an unmarried girl, and these are the cases you counsel. And remember, don't counsel that whatever you read in the books, that hysterectomy might be required and all that. If you tell that, the patient will move from you to other places. So this, remember that you counsel that this is the case, but however, we want to conserve the uterus, and for fertility potential, we want to see that your uterus is restored and your reproductive function, I will try to preserve it. And remember this is the key to myomectomy, going to the proper cleavage and shelling out it, and that is the good result for that. And then after that, you go if you do like that, it's do not enter the peritoneal, the endometrial cavity, and then you can do a layered closure with special reference to the hemostasis at each layer for that. So at least a 3-layer closure has to be done for the future, for the present hemostasis, as well as for the future tensile strength for the scar, so that the pregnancy and other thing can be really tackled with that. So with that, this has been given, and suture is given either a continuous suture or the interrupted suture. You give it, the excised additional redundant portion of the muscle is excised and then sutured, and normally the uterus is preserved in the normal case for that. There's another case where the myoma is there. Is again a myoma in an unmarried girl, and the same procedure. There is a previous history of surgery. Maybe that previous myomectomy must have been done, and now I find that there is a myoma, but there is a peculiarly the adhesions are not much, except in the parietal separation. There was a difficulty of separating the rectus from the muscle. Otherwise, there is not a difficulty for that. So here the earlier case I had shown for hemostasis, I had shown that yes, the vasopressin has been given. But in this particular case, I have a different technique on that, and that's why I have I'm showing this video to you. It's a large myoma, but the myoma is in the upper part, and the alternative methods instead of vasopressin, people are afraid of vasopressin because of the dangers, but it's not like that. And now I'm using this vacuum. Vacuum can be used to deliver the fetal head as well as the myoma for that. This is another way how I do it, and I must show to you the varieties of surgery, because this is an episode of surgical skill transfer, so that I will do that. I will do my best to transfer my knowledge and my skill, whatever I have acquired for the last couple of decades, and transfer to you, and you can do much better. You can refine it. You can also do alternatively a better procedure for that also, the younger generation can do much better than what I can do. So this is how it's a big, it is difficult to deliver it by transverse incision. The incision is small, but it is possible. And this myoma, the suction is very good. Now here the myoma is in the upper part. You can see the ovary and the tube. And now I'm using the uterine tourniquet. This is number 10 infant feeding tube. Number 10 feeding tube, and I'll just find out an avascular area here. The avascular area lateral to the uterine, and anteriorly and posteriorly I bring this particularly this number 10 feeding tube on one aspect, one side, and then subsequently again find a relatively bloodless space. Don't go more medial to that. You go laterally so that the uterine has to be compressed for that. And therefore identify a space lateral to the uterine artery, and this is the avascular space which is there, and you just make a hole there, and just medial to the round ligament and lateral to the uterine artery, and then bring the other part and tie it and suture it, tie it for that. So this is all about the uterine tourniquet. As an Indian indigenous method. Indigenous is indigenous method. We can use this instead of vasopressin, so that the risk of vasopressin is not there, and you can do the good job for that. So here the tourniquet is there, applied for that, and really it works well. The only problem is in the case of cervical myoma, it cannot be used, and the lower side is there. But above that, whenever it is possible, I think you use it and find the benefit. And after the procedure is over, you just remove it. And in fact, it's a very good procedure. Just to show how the uterine tourniquet is used for that, I have shown it. And the rest of the procedure is a anterior myoma. You can give an incision either in the transverse or longitudinal. Here, the longitudinal incision I am giving it. And ultimately, it's absolutely a bloodless procedure. You can do the procedure with the correct space and cleavage, and do the myomectomy in a perfect way for that. So place of abdominal myomectomy in era of MIS, concerns for safety and future reproductive outcome is a major thing for that. This is 25 years, unmarried, presented with lump abdomen, cystic lump, 34 weeks, sonography, benign cyst, and planned for mini lump. There is a 34 weeks benign ovarian cyst. Procedure, midline subalveolar incision, 4 centimeter length, suction drainage of fluid, and I did the salpingo-oophorectomy. This is a case where I wanted to show that a large ovarian tumor, even your gadgets are not there, and these are the cases you just take care that it is not a malignant, and with the 4 centimeter, 3 to 4 centimeter incision, you can approach that and go that this is a rectus sheath, and they enter the rectus sheath, and then after that you enter the rectus sheath and the peritoneum, and this must be a midline incision, and then the cyst is visible, and the cyst is visible. Now you make a small hole, taking precaution of this fluid coming out, and you just put a suction ready for that. Introduce this into the area, into the ovarian cyst, and you find, believe me, you don't find any least fluid coming out and spilling it in the peritoneal cavity for that. I don't recommend that when they know that it's a malignancy, but at least if it's a benign large ovarian cyst, particularly the mucinous variety or a serous variety, and about 5-6 liters of fluid is being enucleated, is being delivered, and then you see that 5 liters of fluid is there in the jar, and then you slowly you find that after that you slowly deliver the ovary, and either you can do a cystectomy or you can do a oophorectomy, salpingo-oophorectomy, depending on the pathology, depending on the choice of all these. So this is an unmarried girl and a large mammoth ovarian tumor, and therefore, and the other cases, the other ovaries and tubes are normal, and it's such a large area. So even if a cystectomy can be possible, you do a cystectomy, or salpingo-oophorectomy can be done with that. So these are the cases where a mini lap can help. So ultimately, the mini lap surgery can be a boon for this type of cases, where instead of the big incision from the symphysis pubis to the Giffey sternum, you can reduce it and then find out, and completely whole ovary and tube, you can make them out and do the procedure, either a salpingo-oophorectomy or the cystectomy. Cystectomy, you identify the healthy area of the ovary where you keep it, and with the precaution to the tube like this, you can do a salpingo-oophorectomy for that. This is another case, again, same thing, about 4-5 centimeter incision, is a large ovarian tumor, and here also the same thing, we did it, but again, this is a case where a large ovarian cyst is there, and is about 32 week size, and same procedure, we can do that for that. And these are the cases where you get a lot of benefit, post-operative morbidity, as well as the procedure is very good for that. And therefore, this has to be considered, and it's not the laparoscopy, it is the laparotomy, mini lap procedure, where the advantage, instead of 3-4 ports, you do it with the 4 centimeter incision and complete the procedure. But the main thing is that preoperative differentiation from benign to malignant is important for that. So this is one, this is another case where you find 6-7 liters of fluid is there. You can do again the salpingo-oophorectomy or the cystectomy. Here is another case, 18 years old girl came with severe pain abdomen and a lump of about 32 weeks. And again, cystic lump and the benign nature, collodoppler is not there. And I have planned for this again a mini lap surgery for that. Mini laparotomy, again a midline incision. You can see that with the 4 centimeter, not more than that, we gave it. And just there is a parietal edema also. And here I was thinking what should be the, so if there is a necessity, I can extend the incision, but there is no need. I can enter into the peritoneal cavity, and after entering the peritoneal cavity, I found that there was a the large ovarian tumor which is gangrenous. And usually I didn't think of the torsion ovarian in such a large ovarian, but this was a case where I was surprised to see that it is a torsion ovarian. The girl was rolling with pain abdomen all throughout, not relieved with that, and therefore I planned this approach for that. And again, this is a case where you can find the torsion ovarian, the black portion. Again, I had to give a incision and drainage of the fluid, and then do a salpingo-oophorectomy. Here I can't, because the ovarian tubes are gangrenous. There is no place for conservation of this particular case. Ovary, I think that needs a salpingo-oophorectomy. Here I find again the fluid, which is, I have to drain that fluid, reduce the mass, and then do the procedure in a as usual manner for that. So here, here I find that yes, the debulking procedure is important. Spilling is not a method, not a problem for that, because we know that in benign malignancy nowadays the aorta criteria and other criteria of ultrasound imaging science has developed to such an extent that collodoppler and the tumor markers are the best guide, which can say that yes, it's not a malignant, it's a benign tumor for that. But it takes a little more time for that, and slowly you just reduce the bulk of the tumor and deliver that, and then subsequently you do a salpingo-oophorectomy. There's not a problem. And this patient was left the hospital after 24 hours, and the girl was very, very happy that in the post-operative period she came and I gave a subcuticular stitch on that, and he couldn't find out the stitch. And this is a case where laparoscopy is not a solution for that. And here I think the mini lap surgery can be a really option, alternate option, and a better option, which I find that is a better option for the particular disease, and this can be done. But the difficulty arises that yes, if I would have given a large incision, it is easier to deliver the things. But again, I say that if you give a larger incision, the morbidity is directly related to the length of the incision for that. And therefore, if it is possible, why to extend the incision for that? If it is not possible, then you extend incision. Otherwise, with the 4-5 centimeter maximum incision, the majority of these cases can be delivered and can be tackled with that. And because this is the only place where the delivery of the tumor is necessary because of the shape, because of the size of the mass. Otherwise, there's not a problem. And incision extension upwards and downwards will really facilitate it. But again, I have not taken into account of that. And this is at last, it could be done. It could be done, and all the tissues could be, the whole ovary and the tube could be delivered safely with that incision and with the traction, and that is possible. The only thing is that the adhesion, the all around in the torsion ovarian, there could be adhesions all around, and that is the only problem which I face here. And but visible adhesion is not found on inspection, and therefore it's a really a difficult case, but it could be done possible, and it could be done very well with that. And these are all gangrenous ovarian tissue which is there, and then it would be possible to remove that. And there is no question of conservative surgery here. The place of the cystectomy is not there with this procedure, and only hysterectomy, the salpingo-oophorectomy could be there for that. Now, at last, I find that I'm come to the end of the procedure of this particular case, and I find that yes, this is about to come, and whole ovarian tumor, whole ovary and the tube is out now, and there is adhesions of that gut, and whole ovarian tumor is out, and it's very easy to put a just hemostatic, I think, suture, or you apply this particularly the vessel sealer and do the procedure. There is a, you can see that there are two torn of the torsion, and I'm surprised. The bigger size usually doesn't go for torsion. The smaller size doesn't go for torsion. The medium size go for torsion. Now you find that this is a torsion area in the pedicle. You can clearly locate the torsion area, and then just with the nick of the vessel sealer, it will be out, and that is possible for that. So this is a case where I can show that a mini lap operation is possible in a case of this magnitude with this size of the ovarian tumor for that. So these cases are not uncommon. Pre-op assessment needed to ascertain benign versus malignant. Mini lap is preferred, technically feasible. Decision for oophorectomy and cystectomy individualized. Post-op morbidity is reduced by overall for that. There is a 32 years para-1 LSCS 6 years ago under investigation for second infertility. Known case of pelvic endometriosis with chocolate cyst, left, presented with acute pain abdomen, fever, dyspnea, abdomen distension, tender lower abdomen with ill-defined lump on the left side, sonography mixed echogenic cyst in the left adnexal region and anterior parietal wall with peritoneal collection, leukocytosis, not responding to antibiotics, IV fluids, features of early ARDS, and therefore planned for laparotomy. Midline subumbilical incision, pus pockets in the parietal wall below the rectus sheath on the left side, extensive adhesion in the peritoneal cavity, infected chocolate cyst on the left ovary, excision was done, peritoneal toileting done, abdomen closed in layers, and the patient was discharged on 10th post-op day. So this is the case where midline incision is given. It's not a, it's like a exploratory laparotomy, and on finding, on exploration, I find the parietal wall, when I run through that, is usually this is the rectus sheath, and when I find the rectus sheath is just cut it, I find the pus, and there is definitely a pus collection, and because of this there could be a septicemia, and you can do the procedure collection. The pus culture has to be given, and drainage of the pus, and cystectomy, that the chocolate cyst, infected cyst is removed for that, completes the procedure for that. So a typical case is not uncommon. Sepsis, wide spectrum, local manifestation to systemic, surgical intervention saves life. Clinical correlation with the technology helps us. This is another case where you find a mammoth ovarian, a benign, and I didn't dare to do a Transverse incision. This is an abdominal incision which I revealed initially. Subumbilical. Again, same thing. For that. But sonography has revealed that this is a case where this is no malignancy is there, and debulking and procedure should be there. And now these are the cases where the whole procedure can be completed by debulking, and a big mammoth ovarian tumor in an elderly lady. And luckily, we could do the hysterectomy with bilateral salpingo-oophorectomy, and then subsequently the procedure is completed with the uterus, small uterus, with the left ovarian tumor, and therefore this procedure, the hysterectomy with bilateral salpingo-oophorectomy, we did it, and fortunately, the came as a mucinous cystadenoma. It's not a carcinoma for that. So these are the cases where we find that yes, there is amenable for. These are the cases laparotomy has to be done, and one should learn to do how to laparotomy. 28 years, case of primary infertility, 3 years, normal cycle, right adnexal farm lump, sonography, right solid ovarian tumor, 8 centimeter diameter with increased vascularity, no ascites, uterus and left adnexal normal. This is 28 years, infertility. So it's planned for laparotomy with imprint smear. I didn't dare for the laparoscopy. Had it been done, it could be done possible. But because of the suspicion of the increased vascularity, phalansteal incision given, no free fluid, uterus normal in control, left tube and ovary normal, right solid ovarian tumor of 8 to 10 centimeter, right tube normal, enucleation of done with increased vascularity. Frozen section was done, and therefore frozen section comes as a fibroma. This is a laparatory findings, and this is a case where the enucleation of the fibroma is done. It's a solid ovarian. And remember, these are the cases one must be very, very sure that malignancy should be excluded. And on enucleation also, I could enucleate it, but there is increased vascularity. And therefore, I thought there could be something, some problem. But therefore, I made a point to make an imprint biopsy, and imprint biopsy came as a fibroma. And that has really helped me to do the conservative surgery for that. So the enucleation of the fibroma has been done rather than removal of this. And this is a young, infertile girl, and I need that this is to be conservative procedure should be done, but waiting for the histopathology, and again histopathology confirms the same finding of the fibroma. So there is a place for the frozen section and the imprint smear, and it adds to the surgical decision making for that. And I did a conservative surgery with the keeping the normal healthy ovarian tissue. So pre-op assessment is suspicion, need for frozen section, and laparotomy is preferred for that. This is a case 22 years, unmarried, with nulliparous prolapse. Approach, LAP approach. So these are the cases whether you can do a LAP approach with the mesh or abdominal. Abdominal is mainly cervicopexy, suprapubic transverse incision, dissection of subcutaneous tissues, strip of the rectus sheath on either side separated, and it's fixed to the isthmus. That is the procedure. So this is a case where secondary descent is there, and cervix is healthy, young, unmarried, nulliparous prolapse for that. So here the transverse incision is mandatory. You cannot do a longitudinal incision. Transverse incision is mandatory because you have to take 2 lateral strips of rectus sheath and laterally, extraperitoneally in the lateral border of the muscle, rectus muscle, and go and fix it to the isthmus. So that's why it is done in abdominal cervicopexy by Purandare method or Khanaj method, or these are the methods. So here you have to separate the up and down, this rectus sheath, the subcutaneous tissue a little in the center. You make it 2 strips, one on the left side and one on the right side. But that's why you want to separate the subcutaneous tissue. Now, one strip on either side, you just take it on the left side, and the right side, you another strip on the other side, and this strip extraperitoneally, you open the abdomen, go transperitoneally, and through that extraperitoneal external opening lateral to the muscle, you just negotiate below the round ligament, you enter into it, and this is a dissection of the uterovesical fold of peritoneum, and approach the isthmus, and then identify that. And this is an area where you have to find out extraperitoneal, the rectus, the sheath has to be brought into the isthmus below the round ligament, and then fixed to the isthmus on either side, so that the uterus is fixed, uterus is elevated, and this is the remarkable surgery by that. The only problem of this is closure, closure of this particular thing, special precaution to the angles, because when you are going for the angle, that portion, the rectus sheath is there, the strip of fossa is there. This is how you enter into the lateral part of the muscle and take it, the one strip of the rectus sheath on the one side, and bring it to the extraperitoneal below the round ligament extraperitoneal to the now you are bringing this and to the isthmus. The same thing, opposite side you do it, and then tie it and then close it like the same thing. The only thing I told that yes, it must be absolutely extraperitoneal, and at times you find that you must be very careful that it goes through that, and now it has come out, and you stitch it both the ends, and the uterus is suspended very well for that. So nulliparous collapse not uncommon. Laparoscopic suspension with mesh is possible, but place of abdominal cervicopexy. 45 years, underwent vaginal hysterectomy 10 days back, presented with pain abdomen, vomiting, abdominal distension, tenderness, sonographic evidence of fluid in peritoneal cavity, nasogastric aspiration, IV fluid, antibiotics, and patient doesn't improve. Plan for exploratory laparotomy. Choice of incision again midline, yellow color fluid in peritoneal cavity, intestinal adhesion separated, small rent, small gut repaired, abdomen drain. So this is one of the complications of the electrocautery, and this is a late presentation of that. Maybe that the bipolar, the non-insulated portion must have touched that, or the upper pedicle must have been hot, and this temperature must have given that problem for that. So this is again another case where laparotomy can help. Laparoscopy is not going to help in this particular case. This is another case where after hysterectomy, laparoscopic hysterectomy, this patient presented with subacute intestinal obstruction, then it is not relieved with the conservative management, then subsequently exploration is done, sonography revealed normal, then on exploration I find that the gut was adherent to each other, adesolysis was done, and there was no rent, nothing like that, but again the separation was there, and because of the adhesion it is there, and therefore then a drain was given, antibiotics was given, and there was a suspicion of rent, but the rent was not there, and this closed with the drain after separation of all these. So post-op surgical complication not uncommon. Early diagnosis and surgical intervention saves life. 40 years para 2, both spontaneous delivery, perception of lump abdomen with pain 2 months ago, abdominal lump 30 weeks, sonography, ovarian mass, increased vascularity, ascites, tumor marker significant, MRI, abdominal pelvic mass, and incision is midline. Again, there is a suspicion of malignancy, advanced ovarian malignancy, radical surgery performed, total tumor clearance, omentectomy, pelvic and parotid lymphadenectomy, appendectomy done, post-op chemotherapy. This is a case where nothing, no compromise about the incision. You take a liberal incision and extend it if necessary. Initially, we have given the subumbilical, but subsequently we have extended above the umbilicus for the parotid dissection for that. And therefore, these are the cases where a malignancy, frank malignancy, ovarian malignancy, we cannot venture to do a laparoscopic surgery, and these are the cases where it is very important to have a preoperative planning and diagnosis and appropriate management for that. So in radical surgery, believe me, for ovarian malignancy, till today, there is no place for the laparoscopy. In cervical cancer, it was there, and still the research is going on by AAGL. And till that time, cervical cancer, the prognosis is much better by doing a laparotomy. And for endometrial malignancy, carcinoma endometrium, the evidence is now saying in favor of laparoscopy, because that you can do it laparoscopic according to the stage, where even pelvic lymphadenectomy in early stage is not necessary. Simple hysterectomy can be of value for that. But here, the important thing is that when you suspect malignancy, don't compromise with the incision. Midline is absolutely mandatory, and extension upwards is absolutely needed for that. So that is the only thing for that. And even ovarian malignancy, I don't prefer that you should give a transverse incision or Maillard incision. Maillard incision, you can muscle cutting, you can give it for cervical cancer, cancer cervix in obese individual, but in particularly the ovarian malignancy. And these are the cases which is very difficult to locate what is the stage of the disease. And particularly in advanced disease, you have to do an extensive surgery and followed by the adjuvant therapy for that. And this very carefully you open up the peritoneal cavity, and the ascites is clearly significant, and peritoneal wash cytology is done. But apart from it, this is suspicious, and then we find that there is a lump, there is an ovarian tumor, and a frank macroscopic gross appearance looks and confirms that it is a case of malignancy. There is no doubt about it for that. But these are the ascitic fluid which has been drained. But remember that here this pill doesn't matter, because already it is in advanced stage for that. So then we extend it. This is a case where the extension of the incision above the umbilicus has to be done. And these are the cases, and the extension of the wound is done after the midline incision. See the no compromise on the length of the incision here when you suspect the ovarian malignancy for that. And after that, the procedure, you just find out, evaluate surgical staging of the disease, and then do a as radical as procedure and as total tumor clearance as possible with the omentectomy and appendicectomy, pelvic lymphadenectomy, and the paraortic lymphadenectomy. So these are the cases where you find that the omental cake is there. Already the omental cake is there. You do a good precisive omentectomy, taking care of the bowel. So laparotomy modality in ovarian malignancy, lateral midline incision with extension needed. Radicality in approach is necessary for that. So this is again another case where you find the uterus is enlarged, and along with that the ovary. See the fungating growth in the ovary, and itself it shows that it is a ovarian malignancy. There is no need of again a frozen section. In that particular case, there is ascites, and the look of that is always suspicious. There is an endometrial cyst associated with this, and you just do that procedure with that. Now, Verdin cystectomy, as I have already told, there is a place for shift towards laparotomy rather than laparoscopic approach, and the incision must be longitudinal or in the transverse with muscle cutting for that. But remember, we can cover the genital malignancy in a different session for that. Just to show the incision, length of incision, it's not much. It can be subumbilical incision, where them can be done, or carcinoma endometrium can be done. But in a case of ovarian malignancy, in advanced malignancy, I think it should be liberalized. Incision must be liberalized. And our gynec oncologist friend like Dr. Giri always advises that yes, don't compromise with that. I have a lot of fight between him and me, because I believe in small incision, mini lap, laparoscopy and all that. But benign, I'm a benign gynecologist, he's a malignant gynecologist. That is the difference. But remember, the basic philosophy is the longitudinal incision and transverse incision with wide exposure, muscle cutting. If it is muscle cutting, is all right. But in ovarian malignancy, is not transverse, is contraindicated, and always the linear, longitudinal, and extension upwards for paraortic, that is essential for that. So thank you very much, ladies and gentlemen, and my viewers. I have crossed the time beyond 1 hour. I think, Sanjay, I beg apology for this. But
no, sir, no, sir. Thank you very much, sir, for the great session.
As a teacher, I don't see the watch. This is my demerit on this. And thank you very much, fellow viewers. Thank you very much, Sanjay, and the whole team of the Zuventus, including the GM. Thank you.
Sir, actually, I will not ask many questions, but there is one case actually, and doctor wants your opinion on that. So I will just read out that. Dr. Purnima Nepran, Imphal, Manipur.
Everywhere. Purnima, always, all episodes she's very careful. Thank you very much, Purnima.
She is asking, sir, I have a patient who has a localized painful swelling near the scar area since 1 year after cesarean section. Can it be scar endometriosis? How can we confirm?
You confirm by the history is absolutely confirmatory. If it is a cyclic pain and over this scar there is a tender lump, is nothing but scar endometriosis. There is no doubt about it. But to supplement it, the parietal sonography can confirm it that there is a mixed echogenic area over the scar, which confirms that. But clinical is mostly diagnostic.
Okay, sir. Thank you, sir. And there are so many admiring messages regarding your zealous, enthusiastic teaching, sir. So they are pouring.
Thank you.
Thank you, sir. Sir, again, one small question. Neeta Arora from Mirror, she is asking, sir, which vessel sealer you are using and what is the cost of this?
I'm using a varieties of vessel sealer. I have used all types of vessel sealer, starting from Ligasure to the Martin to the Desi Hamara Alan. Alan I'm using, and I find the Martin is I'm very comfortable with Martin, because the other vessel sealer like a Ligasure and all that, the recurring expenses are more. But the vessel sealer which I have used it since 2005 onwards, that at that time it was with one bike lamp I have done 5,000 hysterectomy, and that is a cost effective thing which I prefer that. And of course nowadays the Indian surgeon, Indian companies are also very good, and it's a cost effective also. I've used the Alan variety. Alan as a combi pack is a very good equipment which has everything, monopolar, bipolar, vessel sealer, and underwater cautery also with that. And with that, they have an added advantage of a shear. Shear means you just coagulate and cut at the tip. So that is okay, and cost is half the price of the international.
Yes, sir. Yes. Sir, Dr. Sanjay Das from Jatni, Orissa, he is asking how to prevent adhesion, keloid.
This is a $1 million question, Sanjay. Keloid, the origin, the pathogenesis, origin of the keloid is individualized. The patient response to the adhesions are varying. Number on the why there is an adhesion after surgery. The first important is your surgical technique. That's important. And second important is your patient's profile also. So even if the surgical technique must be first, if surgical technique is good, and the keloid is more often a patient related, so there are tendency of the scar hypertrophy in some of the individuals for that.
Yes, sir. Sir, next question is from Uma Gupta, Lucknow. She is asking about urachus. How to break it, urachus?
I have seen one case particularly. Otherwise, the obliterated and fibrous strands is not patent, and there is no problem in cutting it. So whenever one case I found, when I cut it, I find that there is a urine leak, watery substance coming out. So I ligated that, because I have earlier seen one case where somebody has done it, and I find after the surgery, 10-15 days after, there is a continuous dribbling of the water from the wound. And then when I did the cystoscopy, I could confirm that there is a connection to the urachus is there. So simple prevention. If you just find a thicker band and you cut it at both ends, in the proximal and distal, I think that saves life.
Yes, sir. Sir, next question is from Ganesham Jain, Orissa, Titligarh, and he is asking about buttonhole incision. He want to know about buttonhole incision.
Ghansham is my close friend, and yes, in gynecology, I think which type of incision you are telling? I'm not able to hear.
Buttonhole.
Oh, buttonhole. Buttonhole incision is same as the laparoscopic port entry, and these are all this cannot be fitted into the laparotomy part for that. Buttonhole incision, I have categorized that laparoscopy minimal incision is maximum up to 20 millimeters. If a 20 millimeters there is there, and usually 10 millimeter up till 10 millimeter it is acceptable, and 5 millimeter, 7 millimeter, and 10 millimeter. This is laparoscopy. 10 to 20 millimeter, you can call it as buttonhole. 20 millimeter to 50 millimeter, you can call it as mini lap. More than that is called a laparotomy.
Yes, sir. Yes, sir.
Thank you very much that you are observing.
Oh, thank you, sir. Thank you very much, sir.
Thank you. Thank you, Sanjay. Sir. I have crossed limit, and sorry for
yes,
that.
Sir, yes, sir.
I have almost 3.5 hours. I think 3 hours and 15,
yes,
20 minutes.
But sir, session is very engaging, sir. It was very engaging.
I'm sorry I don't see the watch. Now I'm seeing the watch. I've crossed limit.
Yes, sir.
Thank you.
Thank you, sir.
People are enjoying the
Thank you, sir.